Check, 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 test, hey, check, check, check,
Hi, check. How are you? Check, check. Okay, noted.
Very good morning to all of you, and welcome back for the second day of Upgradio 2024. So today we have some exciting sessions on TAVI, STEMI, and some newer innovations. So starting with the first session, which is TAVI, and the chairperson for this session is Dr. A. Srinivas Kumar. And the first topic which we are going to take is case selection, clinical and echo by Dr. Samir Srivas.
Morning, everybody. I think we'll have case selection of ECHO by Dr. Samir Srivastava first. I thank him for coming all the way from Delhi for this program. As the starting trouble in our country goes on, I think people will join. So then we'll go on to technique proper in cath lab like access, and then take you step by step of TAVR and see the complications session by Dr. Ramesh Dagupati. Request Dr. Samir to come. Can keep the session. Can keep the sessions interactive. If anybody wants to ask any doubts, feel free to stop and ask. We want it to be more two-way discussions.
Thank you very much, Srinivas. You don't have to be that polite with me, at least. So, and that's something which all of us would want, that wherever you feel that there is any confusion, understanding, please interrupt us and do that shamelessly. So, I'm going to start with, can I have my slides up, please? Now, aortic stenosis. Now, I'm going to start with, clearly you find, can we have the lights down, please? Clearly you find that the aortic valve is thickened, it is calcific. There is some mitral annular calcification here. And if you look at it in total, this seems to be an elderly person with a severe mitral stenosis. Let's look at the parameters. The parameters are that his Vmax was 4.6, his mean PG was 52, AVO was 0.7 centimeters square. So clearly he is a severe aortic stenosis. Now, when you come to severe aortic stenosis, fortunately across the Atlantic, there was a very major confusion between the European and the Americans that whether mean PG of 40 should be taken as a severe aortic stenosis or 50. But now if you look at it across the board, if there is a Vmax more than 4 and mean PG more than 40 and AVM more than less than 1 centimeter square, it is graded as a severe aortic stenosis. But where is the problem? The problem is that this man of ours, roughly, if you look at it by his echo parameters, mitral annular calcification, degenerative aortic stenosis, sclerotic, he would be somewhere in his, he would be an octogenarian or somewhere. But that besides, the biggest challenge is that he's absolutely asymptomatic. Now, asymptomatic severe aortic stenosis, where is the data saying take us to? Because till very recently, conventional teaching was severe aortic stenosis, don't touch them with a mile-long pole. Let's see what the data is. So if you look at the data collected by Otto, whether it was Rosenheck, whether it was Pellica, or whether it was Stewart, everybody showed that as time passes with severe aortic stenosis, there is a decremental survival pattern. So where are we? Are we missing something? Because till very recently, people said, no, they don't die. So if they're asymptomatic, truthfully asymptomatic, they don't die so soon. Now, This is for asymptomatic severe aortic stenosis. So subset analysis came happening, and Rosenhack was a little more uh, uh, um, robust and more dramatic in approach. They also calculated the calcium score. When they did the calcium score, they found that even for asymptomatic aortic stenosis, look at the divergent graph. Mild calcification versus severe calcification, the survival patterns were so very different. Now, this is severe aortic stenosis, and subsequently, they also started studying what are the gradient effects like in, again, an asymptomatic severe aortic stenosis. Look at the graph. The one in the line is when the Vmax is more than 5.5. And this is the reason why across the Atlantics, both sides, they were forced to change their guidelines and recommendations. Now, the problem is with asymptomatic severe aortic stenosis, and current management challenges are also for low flow, low gradient, and severe AS. So what is the risk of death while waiting for symptoms to trigger AVR? Now, where was the issue? Issue was that natural history of severe aortic symptomatic stenosis was such that if you gave them an option of aortic valve replacement, the chances of dying were more of surgery than leaving them without surgery. So they said, wait till the time they become symptomatic. Now, here is Pai et al.'s. This was not published in Circulation, Lancet, New England Journal. No, it was published in Annals of Thoracic Surgery, because they said this is too dramatic a story in natural history, because everybody who was diagnosed as asymptomatic severe aortic stenosis, from day one, they started dying more. As against most Gang, Taniguchi, Nistri, all of them said that they have a fairly stable period before they start dying more than what the statistics would generate. So this is where Pai's dichotomy was. And now, Taniguchi was even more bold. What he did was, he took two subsets of people with severe aortic stenosis, asymptomatic. One, he followed them up conservatively. Another, he subjected them to surgery. Again, look at the divergent graph. People who had ABR, they survived better. But most of us who are fixated with our own teachings and learnings, they have learned over a period of time, asymptomatic severe aortic stenosis, don't touch them with a mile-long pole. So where are we? Where are we missing the bus? So that subset of population were so immensely impressed by their own thoughts that they did a subset analysis, and they found that 31% of patients who developed symptoms did not have an AVR, and they subjected themselves not to undergo. And this contributed to 17 deaths. So the jury is still not home yet. So where are we? In America, now severe aortic stenosis with Vmax of more than 5 meters per second is class 2A indication. Rapid progression and lower surgical risk, if you have, then this is not that strong an indication, but you can push them across into the eastern side of Atlantic in Europe. Very severe AS, they are a little more conservative than the Americans. They say that 5.5 should be the cutoff, again, class 2A indication. And another thing which they did include was severe valve calcification and rapid progression. What is rapid progression? More than 0.1 centimeter square per year, more than 10 millimeters of mercury increase, or there is a fall of 0.1 centimeter square of valve area in a year. Now, there is yet another developing indications which are entering. That is markedly elevated BNPs. An increase in gradient with exercise more than 20 millimeters of mercury is a class 2B indication. Also, LVH independently is being discussed. Why? I'll come into that issue a little later. So these are the indications. The Americans have really lowered their threshold for surgery in asymptomatic patients. And Europeans, they say that you have to have severe AS, severity of calcification should be included, left ventricular function and exercise response. These are the ones which use. So somewhere the consensus of opinion is developing in the world. And severity of calcification is something which has been done recently, where they found that if for men, the calcium score is more than 2065, and for women, if it is more than 1274, then it constitutes what should be done as an indication for valve replacement. BNP, yes, compared to the baseline population, if your BNPs are more than 3, then it's a softer indication, but yes, it is an indication all the same. These are the ones which are being worked: troponins, soluble ST2, anti-proBNPs, etc., etc. Now, where are we? These are the values and numbers which have to be calculated in transthoracic. The ones which have really to be done is you have to see whether it's a bicuspid or a tricomistral valve. Bicuspid aortic valve these days is not a disease of the valve. Bicuspid valve is a disease of aorta. It's an aortopathy. And that's the reason whenever there is a bicuspid aortic valve, see this. This is clearly a bicuspid aortic valve, but you go a little down, you'll start finding that this is a fused raphe at the base, at the tip, and at the base, they are relatively free. Now, why is it so important? Because with the bicuspid aortic valve, be very careful to assess the ascending aorta. If your ascending aorta is more than 4.5, this person rather goes for a Bentals rather than going for a TAVI, though the indications are becoming shorter. So here is how you have to take the measurements. You have to take it at the root, you have to take it at the sinotubular junction, and 4.5 centimeters away from the annulus. And this is the place where you'll get the maximum dilatation, expectedly so, just in case dilatation has to happen. This is how you measure beyond, and this is how you take the measurements. Now, just to introduce one more term to the fellows, there is something known as low flow, low gradient, normal LV, severe AS. So paradoxical. If the LV is normal, if there is a severe AS, why should it not generate gradients? But several times it doesn't. This is known as a paradoxical aortic stenosis. Why does it happen? So there are 3 reasons why it happens. One is that because of very thick LVH, the quantum of blood which it receives in diastole is so little that for that little blood to eject out, it does not need to have very high gradients. This is the most favored hypothesis. Number 2, if there is a person who is hypertensive, the hypertension per se will reduce the gradient across LV to aorta and systole. And third is that you don't know. Maybe the patient had 70% ejection fraction, and now when you're measuring it is 55%. So this person is behaving like a low flow, low gradient, poor LV, or relatively poor LV. So these are 3 reasons why paradoxical aortic stenosis has to be addressed. And how do you diagnose it? It's very interesting. Start taking multimodality imaging the moment you start finding that there is a LVH in ECG, there is a concentric LVH in echo, the gradients are not high. You do a transesophageal echo, your area is 0.8, gradients are not high. Start utilizing multimodality imaging. Not only did that, CT scan is probably one of the best, because not only does it give you a valve area across the aortic valve, it also gives you a calcification of the valve only. And of course, have your clinical subset well established. Now, what are the outcomes of impact when you operate upon these paradoxical aortic stenosis? If you look at the odds ratio, the odd ratios are favorable for AVR protective, but not significantly so. So again, in this subset, jury is still not home what to do, but the debate continues. Now, just in case, the conventional low flow, low gradient aortic stenosis with poor LV. So if you find that there is a poor LV, start doing a dobutamine stress echo, document increase of Vmax more than 4, document mean PG going more than 40, document falling off aortic valve area less than 1. And if there is a reduced ejection fraction, and of course, the Europeans talk about the contractile reserve. Contractile reserve is that in case your ejection fraction is not increasing by 20% from the baseline, then you are in big time trouble, because not that it precludes you from changing the valve, but what it does is it tells you that the prognostically these people are not probably going to do as well. Now, this is what I just talked about, paradoxical aortic stenosis. It's a very dubious indication. Only if clinical, anatomic, and hemodynamic data supports severe aortic stenosis, then only do it. And unfortunately, when the gradients are not that high, this is going to be a little paradoxical thing to prove. Europeans, as against this, they are more conservative. They say that only after thorough confirmation of severe aortic stenosis should you do it. So this is the time when you should start using multimodality imaging. So how do you diagnose classic low flow, low gradient? Low flow, low gradient, poor LV. So you have to have ejection fraction less than 50% and systolic volume index less than 35. How do you diagnose paradoxical aortic stenosis? You have to calculate the systolic volume index less than 35, ejection fraction more than 50, and rest of the things fall in place. But here there is one more important thing, that you have to have thickened valve. The ratio of should be more than 0.5 of posterior wall thickness to left ventricular end diastolic dimension. So this is what is there. And also, if you document myocardial fibrosis on MRI, and if you get a grossly reduced GLS with normal LV, start suspecting amyloidosis, start suspecting paradoxical aortic stenosis. Good 20% of severe aortic stenosis patients would be amyloid. Not only that, utilize global longitudinal strain, and if your strains are low, then start thinking in terms of paradoxical aortic stenosis. Not only that, do TE for all, because many a times you'd be surprised like this. This is nothing but a intramural hematoma, and you can find dissections. We have found here it is again intramural hematoma with some paradoxical changes. This is intimal thickening. There are certain neurodimensions in a setting of TAVR or TAVI, rule out subaortic membrane. Distance of coronary ostia from base of the aortic leaflet should be more than 10 millimeters. Large calcific valvular nodules or not, because this can really alter the geometry of the valve. Highly calcified aorta is a challenge, though it is an indication too. Aortic root dimension should be less than 45 millimeters at the sinotubular junction, because if it is greater than that, this person might as well go for Bentall surgery. Very hypertrophied septum, because these are the ones, the moment you reduce their afterload, changing the valve, this hypertrophied septum starts behaving like a hypertrophic obstructive cardiomyopathy. So you have to be very careful, because post-TAVR, if your pressures are falling, start hunting for LVOT obstruction. Start looking at pericardial effusion and tamponade. If these two are not there, give them fluids, give them norepi, don't give them epinephrine, don't give them diuretics. These are the patients who will worsen with that. And aortic annular size, these are moving targets. 11 to 29 millimeters is the upper limit, but there are valves which are larger than that. There are valves which are smaller than that. So this is a dynamic goalpost. Now, we have lost the race as echocardiographers because CT scan has become the gold standard. Somebody is going to talk about it. But newer softwares are available for quantitative assessment of aortic root. What is needed is T aortic root image with real 3-time T, and just follow a few simple steps, and what you'll get is a cast. And with this cast, you can get the numbers, you can get the diameter, you can get the mean, you can get all the things possible. But again, the paradox is, when MRIs in their initial days had to be validated, they were validated against echo. But these days, echo things are being validated by CT scan and MRI. So these are paradoxical things that we all live with. And this is my last slide. Aortic stenosis is a game of sleuth game. It is detection. Don't look at only one thing, because if you look at only one thing, you'll see what you want to see. In the bargain, you can miss a beast. Thank you very much for your patient listening. I'll be very happy to answer any questions.
Thank you, sir, for covering it so well, taking up all the subsets of aortic stenosis. As you understand, when we become more perfect with the therapy, when you're confident enough to deliver the therapy with less mortality and morbidity, like how surgical AVR improved, now TAVR also will come a long way, where we are able to do justice even in low-risk patients. That's how the criteria of surgery is also being reduced in the That's how sir brought it down. Though the natural history studies also showed it will be beneficial. And some initially only when the echo-based towers were being done, because it's not always circular. Sometimes it could be oblique, elliptical, annulus. Then we were landing in trouble with parallel leaks and things like that. That's how CT scored slightly advantage over that. And then TE reconstruction could again throw some more light in future. That's what sir has covered. But anything, any other doubts regarding any echo evaluation? How any of you are part of this evaluation by continuity equation or aortic valve? Like what sometimes when the gradients are less, and you feel that aortic valve opening is not well, calcium sir mentioned that you also check those parameters with that. Either on that or any other aspect on GLS, any doubts you have, you can ask, because sir has to leave, I was told. Other questions we can take later, but anything pertain to echo, please clarify from him now. It's on the mic.
A discrepancy between echo and cath gradients.
So actually what echo does is mean gradients. That is what is more important. And catheter-based gradients are peak to peak. So there is always a delay between LV contractility and the aorta. So what you have to do is you fallaciously underestimate the gradients. And more people are talking about mean gradients and calculation of mean gradients. We have seen calculation of mean gradients during BMBs, to calculate mean LA pressures versus end diastolic gradient was so simple. But when it comes to peak gradients versus mean gradients, there is a lot of discrepancy. Trust the mean PGs of echo.
Between TAVR success in a case of senile calcific severe AS versus bicuspid aortic valve causing AS with aortopathy.
But because aortopathy is something where you don't need to do a TAVR.
With severe AS caused by bicuspid aortic valve, then
Aortopathies are to be managed surgically. I need Sandeep's comment on this.
I think when you are asking differences between bicuspid and tricuspid aortic valve, that will have discussion after the end of the TAVR sessions. But aortopathy as such, if the aorta is dilated, as I said, you might need ventral procedure. So Sandeep.
No, see, bicuspid aortic valve is an off-label indication. I'm aware of the fact that many people are doing it, but it is an off-label indication. It is not a recommended indication for TAVR. That we need to understand. And secondly, bicuspid aortic valve patients present quite younger. At the present time, age less than 65. The best window that you have for TAVR is between 65 to 75 or max 80. Those are the patients where where TAVR is going to do very well.
Diameter also said.
Yeah, he mentioned the diameter. That of course is clear aortopathy. There it is not indicated at all. I'm talking of the subset where there is a bicuspid aortic valve, but it is not associated with dilated aorta. So even there, it is not indicated in the routine matter. People are doing it. I'm fully aware of that, but that doesn't mean that's the correct practice.
Indications might come in future, sir, because 60% of the procedures which are done in China and 50% of the procedures which are done in India are on bicuspid aortic. I keep joking with Sushil that you can learn these things from us. It's because somehow incidence of bicuspid aortic valve is very high in China and India, whereas in US they're not comfortable doing it. Though they have also started after this multi-center analysis of done by Raj Makar. I touch in between the discussions, so that it showed no difference between the outcomes and mortality. That's why there's more case for going. It might come in future recommendations. But definitely one thing what sir was highlighting was bicuspid aortic valve associated with hugely dilated aorta, which needs to be tackled. That has to be surgically corrected with Bentals with valve replacement. Though some sick patients, interventional cardiologists started doing even putting aortic grafts, then endograft, then putting a valve inside it, which is very high risk and cumbersome, or to be done only in surgically totally unfit and dying patients as a palliative life-saving measures. But as of now, the recommendation is for surgery for those patients. Thank you, sir. I think you want to announce?
One last comment for the boys, just in case they ask you, aortic size more than 5.5, regardless of aortic valve, is symptomatic. Whether aortic valve is normal or not, they need the correction. 5 with bicuspid aortic valve, 4.5 with bicuspid aortic valve with Marfan's. So these are the numbers which you need to remember for answering an exam. Thank you very much. One more, shoot.
Yes, sir. Is there any like hypertrophy septum is the absolute contraindication, or is there any way to evaluate in echo whether there is dynamic LVOT because of the hypertrophied septum?
Correct. So if I had some time, I would have shown you there is something known as a gradient in gradient. You can see a gradient, which is like a dagger-shaped gradient, which looks like a hypertrophic obstructive cardiomyopathy, which gets embedded in the U-shaped or parabolic gradients. So these are the places where you have to have your eyes and ears very clearly available. If you are seeing gradients across LVOT, inform that just in case there is a fall of blood pressure, give fluids, give beta blockers, and give norepi in case needed. Don't give inotropes, don't give diuretics, don't give anything except these. So these are three things because you want to increase the afterload. The moment you take out the aortic valve, what have you done? You have reduced the afterload suddenly. And this LV hypertrophy starts behaving like a hypertrophic obstructive cardiomyopathy. And so what you need to do is you have to do everything which is not to be done by the post-operative critical care team.
If your doubt was whether to do TAVR in such patients or not, then generally, even the hypertrophied subaortic obstruction also might be there with associated aortic stenosis severe. Once you relieve it, this might manifest a little. The way how to tackle that, sir, is explaining. But if the dominant obstruction is a aortic valve, still we are doing TAVR in such setups. But while doing TAVR, you need to follow some specific precautions to prevent valve pop-outs happening. So subaortic membrane, below it, the membrane is too much hypertrophied. When you're trying to inflate the valve will pop up into the aorta. There are some precautions to be taken, especially when you have LVOT and the subaortic membranes, which are very hypertrophied. That will cover up in the procedure discussion. Thank you, sir.
Thank you. But be careful. If it is a severely stenosed valve with grossly septum, especially at the bases, which is gross, involve the heart team because surgeon can do probably a better job by putting in a valve and doing a myomectomy with a standby need for surgery because for pacemaker, because calcific aortic valves, when you dig out and especially do the myomectomies, chances of needing a pacemaker are high. Thank you very much. I think I have overboarded my time.
Thank you so much, sir. So if you can just please wait for your felicitation. So I would request Mr. Tapas Mukherjee to felicitate Dr. Samir Srivastav, sir. Please give a big hand. Thank you so much, sir. So next we have a session on vascular access and closure basics and beyond. So to take this session, I would invite Dr. B.V. Rangareddy. Can we have the CV of Dr. Rangareddy? Yeah. So Dr. Rangareddy is the consultant interventional cardiologist at Apollo Hospitals. He is the professor of cardiology at Apollo Hospital, Hyderabad. He has expertise in various clinical and interventional cardiology related techniques. He has a special interest in carotid, peripheral, endovascular, and structural interventions. He is a fellow of International Medical Sciences Academy since 2016, and he has published several papers in various international journals of repute. So over to you, sir.
Yes, it's coming actually. Good morning, everyone. I'm Dr. Rangareddy. So my topic is vascular access and closer, basics and beyond. Let's get right to the point. Mainly for the TAVR access sites, these are the main access sites generally we use. Most regular used is transfemoral. And the other means of approach, when you are not able to, when you are checking in a CT iotogram or femorals, and already if there is a peripheral vascular disease and you want to approach through other means of access other than transfemoral, then the next thing is we'll try going through either subclavian axillary or the carotid approach. Then even if those access are not available, then we'll try for the thoracic, that is transaortic or transapical. So how do we choose what's favorable conditions for the transfemoral access? So first, initially, when we are assessing the calcification and when we are assessing the vascular access in the CT or uh, ultrasound. So first thing we need to look at is whether the sufficient lumen diameter is there or not. Especially generally we see like till 6.5, at least 7.5. Basic, it's an ideal. At least 6.5 we'll see. And if the circumferential calcium is less than 270, and not only circumferential calcium, the location of the calcium is also very important. I'll show you in the later slides. And the absence of severe anterior wall calcification and no significant tortuous. If these conditions were applied, then if it's favorable, then go for transfemoral. If not, then the alternative will think of axillary subclavian. The same thing, the sufficient lumen diameter, circumferential calcium less than 270. And if any patient who already underwent CABG and patent Lima graft, it will be it's not a complete contraindication, but there is a high risk of stenosis and a high risk because of the Lima, if it's a patent Lima is there. And subclavian to aortic arch angle less than 80. If these things are favorable, go for axillary or subclavian. Or if these things are not favorable, then the other means transcarotid. The same things applies mainly, especially if there is an absence of contralateral internal carotid stenosis or occlusion, then you need to look after this. And if there is significant tortuosity, then think about alternative. Or these favorable conditions, then go for transcarotid. And non-favorable, then depending on the experience and depending on the center experience, the anatomy, you can go transapical, suprasternal, brachiocephalic, and transcaval. So what are the advantages and disadvantages in these means of access, especially femoral, transfemoral, the most widely used vascular approach, and less invasiveness, ability to perform without general anesthesia, shorter hospital stay, ease of patient recovery, and you can just do a full TAVR procedure with sedation and in local anesthesia. Main disadvantages, the vascular, so when we're assessing the vascular access, like especially the tortuosity, the presence of extensive atherosclerosis and calcification, So these things are the disadvantages through transfemoral. So transcarotid, it's a less invasive than transthoracic access. So straightforward procedure with many similarities with the carotid endarterectomy. So transcarotid, what are the disadvantages? So it has a very high risk of stroke. So especially when we are thinking of a transcarotid, the prior assessment of neurovascular assessment is very important. The supply of patency assessment of circle of Willis and the follow-up data also, because it's an alternative to transfemoral. If there is no access, there is very less data and less number of patients which were accessed through this. And even as it's compared to femoral, carotids are thin and frail. So risk of vessel injury is higher compared to transfemoral. Coming to the axillary and subclavian. So subclavian, it's a less invasive, definitely compared to a transthoracic, and a shortest period stay and decreased need for general anesthesia. It's almost procedure is similar to transfemoral approach. And especially in this, the restrictions mainly comes with the caliber and the presence of calcification. And post CABG, as we discussed before, Lima graft, if there is a patent Lima graft, the risk of complications are very high. We better to avoid if there is a patent Lima graft. So in most cases, it requires a cut down procedure. Risk of brachial plexus injury due to proximity of the vessel is very high. So transapical approach, it's very like this have fewer vascular complications, but we need to involve CT surgeon for this, and fewer contrast and fluoroscopy, short distance from the sheath. It improves the valve alignments and the fewer paravalvular leaks. It enables the accommodation of the larger sheath. So what are the complications in this? So there will be a significant myocardial injury in this. It's an invasive technique. Complications related to the puncture site bleeding, ventricular pseudoaneurysms, and coronary artery damage, and relative contraindications for impaired LV, and especially patients who are having LV dysfunction. And these type of patients, they have very high risk when we are approaching through transapical. So transaortic, this also it's an invasive approach. It will be easier for us. Actually, so surgeon will access it, and it will be a direct access, and the positioning will be easier. And aorta facilitates the valve positioning and the large sheath insertions. And it's a familiarity of trained operators for accessing and cannulating the aorta is very important, and less bleeding risk compared with the transapical approach. So what are the complications, disadvantages in this? It's an highly invasive access, especially it requires sternotomy and mini thoracotomy. It's a very high risk for patients who have a prior sternotomy or prior bypass surgery or prior valvular surgery. These patients, they'll have it will be a very high risk. And contraindications, especially like the aorta, any complications with aorta, any aneurysmal complications, post stenotic aortic dilatation. These patients, they'll have high complications of rupture and bleeding. A transcaval approach, femoral vein is not subject to the same limitations as the artery. Last percutaneous option, if no other means of approach is available. Especially this disadvantage is it has a very increased risk of bleeding regarding the venous aortic closure and short and long-term hemostasis, caval aortic. Very few studies and very rarely this approach was done. There are not many studies to favor this access sites. So planning as a regular access especially transfemoral, planning is very important. So prior to the deciding the procedure, TAVR procedure, CT iotography scan with 3D reconstruction of aorta femoral vessels is very important. Aorta should be assessed for the tortuosity and presence of any aneurysms, atherosclerotic plaques, and aortic arch calcifications. So the minimum size of femoral and iliac arteries, it should be more than 5.5. Ideal will be say more than 6.5. It should be free of calcification. The circumferential calcification could be a very potential contraindication for transfemoral approach. Some studies show the sheath femoral ratio depends on the valve also, whether the size of the sheath. So sheath to femoral artery ratio of greater than 1.05, it's predictive of a vascular complication. So bifurcation of femoral artery and its relation with the femoral head, it should be evaluated properly before the assessment. Site of needle entry may be altered based on CT scan or ultrasound findings, or high bifurcation of the common femoral artery and presence of significant calcium. So this. So this is taken in our cath lab. This is an ultrasound guided access. So you can see the bifurcation in this initially, then the short axis. In the short axis, you can see the entry of the needle. So you can see the entry of the needle. This is very important, especially in the TAVR procedure when through femoral access. So you can see the entry of the wire needle. So this is an ultrasound guided puncture, especially when we are trying to, after the procedure, when we are using the closure devices, if it's a lateral approach or if there is a calcification, it will be very, complications will be more when we are trying to close with the closure device, the post procedure. So ultrasound guided CT assessment will be before. During the puncture, ultrasound guided assessment is very important. This we have discussed. Okay, sir. So we'll just go to the evaluation of vessel size, like how to evaluate when we are, especially the transfemoral, the traditional CT aortography, mainly we should assess aorta, common iliacs, external iliacs, and common femorals. So when we are assessing, you should use the bone window to assess calcium and luminal vessel size. So if there is a calcium, when you are measuring, you should measure from inside the calcium and not from the like intima to intima. So important to measure the vessels on force and not on angles or bends, particularly important for external iliacs. So 3D reconstruction is very useful to check the tortuosity and even the calcification. We can check in the 3D reconstruction where exactly the calcium is significant. Because during the procedure, before itself, we need to evaluate the calcium, whether if it's 180 degrees or 270 or 360 degrees calcium, and where is it position mixed, whether if it's a mixed calcified plaque or any thrombus, or whether it posteriorly placed in the common femoral artery. You can see in this, it's a posterior plaque in common femoral artery. So 3D reconstruction, you can assess the tortuosity and the calcification. So evaluation of tortuosity is very important. Very important in 3D reconstructions, vessels which are tortuous but not heavily calcified, often it can be straightened with a stiffer wire, and vessels which are tortuous and heavily calcified are not favorable for transfemoral approach, especially in TAVR. So coming to the closure devices, femoral vascular closure devices, it can be divided into two categories, active and passive. Passive closure devices, it's with a mechanical compression or by increasing the thrombosis for effective hemostasis. So however, passive devices do not hasten the actual time it takes to a time to reach the hemostasis. And so active closure devices, they include suture devices, collagen plugs and clips. The indication for using a femoral vascular closure device is to achieve hemostasis through successful closure of the femoral artery puncture and to decrease the time to attain the successful hemostasis. Hemostasis for large bore access sites for structural interventions is routinely achieved using femoral vascular closure devices. Contraindications, if it's above the inguinal ligament or through the superficial or deep femoral arteries, lateral surface of when you're puncturing through the lateral surface of the arterial wall, and multiple attempts were done during the puncture, or any bacterial infections around the site and heavy calcification in and around the access sites. Caution should be taken, especially patient who is on anticoagulation with warfarin, thrombolized patient, bleeding dialysis and peripheral vascular disease. This is one of the compressive, I'll show you. So these are the different vascular closure devices which are available, especially mainly we use the Perclose device. It's an intravascular percutaneous delivery system of suture to close the access site. I'll show you. So these are the different available vascular closure devices. ProGlide, which we regularly use, it's a suture-based intravascular, and we have Angioseal, we have InSeal. So these are the different devices. I'll show you. So Angioseal also we regularly use. This is a collagen-based device to. So these are the devices available, mainly Perclose, Vasoseal. Vasoseal is like Angioseal we use, Starclose. These are the other extravascular devices, Minx, Exoseal and all. We don't have this, but Angioseal and Perclose, which we regularly use. So what are the complications? Main vascular access complications commonly occur at the site of the access, and bleeding or hematoma formation occurs most frequently. Prevention, early identification, that's why the assessment is very important before planning the procedure itself. And we should understand like what are the complications. So whether if it's whether we need to use one pre-closed device or two devices or along with an angioseal. So these things to be prepared before itself or when we are accessing the transfemoral. So prevention, early identification and managing the patients undergoing TAVR. The incidence of vascular complications has varied according to the definition that has been applied. So in patients in receiving first generation valves, around 12% of patients experienced a major vascular complications.
Ranga, we have Ramesh talking on complications.
Okay, sir.
He's waiting.
So this is one of the typical example of a vascular site complication associated with transfemoral TAVI. Ramesh sir will talk about this. Thank you.
Thank you, Ranga. You wanted to do something? I think we'll have discussion. Dr. Ramesh Dagupati sir is waiting to deliver his talk. We requested him to talk on something about CT angio evaluation, which Dr. Gokul couldn't do it, and also he'll talk about complications later. Before that, I think Lupin wanted to felicitate Ranga with some certificate. Later. Okay. After the session.
Yeah. After.
Okay. I think can you connect to Dr. Ramesh sir? Yeah.
Yeah, I can hear you.
Yeah. Now, thank you again, sir. Always ready to help in any form. And in spite of his, he's occupied with some other conference there, but still he requested him to cover up with us Zoom. Thank you, Ramesh. And we are able to see and hear you. Hope you can. You did slide check once. You want to show? Do that.
Yeah, Yeah, I'm trying to share my screen. Can they enable that? So thank you very much, Dr. Srinivas Kumar. It is a great pleasure to be with all of you. And I think, obviously there's so many conferences that are happening. And obviously there's a conflict once in a while that we come across. Let me first, okay. Can you see my screen? And
Yes, we can see it, sir. Good.
okay. So
Can make it full screen, I think. Yeah.
yeah, that's
Yeah, right. Perfect.
so all right. So it's not exactly what Dr. Gokul is going to talk about teaching 3-Mensio. I think that is best learned at workstations with several computers. I'll be just talking on imaging in tower. And very nice talk by Dr. Reddy about vascular access and closure devices. So it has been about 34 years since the idea of tower has come in, and now we do about nearly 80,000 towers in the United States in a year. And original idea was born in 1988. And as you see, this is a 3D TEE, which is very crucial in looking at how you can even see the balloon being inflated in the aortic sinus, aortic root. And so I think this is a very nice 3D images that you can obtain. And in intermediate and high risk patients, it's always, I think, useful to have TEE or wherever you suspect that their patient's going to end up with some problems. In pre-tower imaging, the most important reason is to know what exactly the valve size should be placed. And so depending upon aortic annulus measurements, there are different valve sizes that you can choose. You can also look at the guide position and deployment by TEE and detect complications such as aortic root ruptures, or if there is a really significant wall motion abnormality that might suggest a coronary obstruction as well. So in expert hands, the 3D TEE is good, but I think otherwise in majority of the people now, the gold standard has, CT has become the gold standard in analyzing aortic root anatomy in complete. So this is a 3-Mensio software, which I think you can learn. It is a licensed software, quite expensive for individual people, but I think the hospital we have available on our computers because of the purchasing through the hospital. So we can analyze on each and every patient, or you can use sometimes Osiris is another free software that is also usually free for 1 month or so. And you can look at the aortic annulus here that actually you can measure it. And annulus is usually about 1 to 2 millimeters below the aortic, what we call as LVOT. And so here's the LVOT. And depending upon which is the smallest size, you might actually choose the size of the valve based on that. Or if the LVOT is too small, I actually think that I go intermediate between the annular size and the LVOT. And then you can look at on the higher up as you go from into the aortic root, sinotubular junction, and the sinus of valsalva diameters and the sinus heights as well can be seen with the left coronary and right coronary, and the coronary heights. All of them can be seen on the CT scan and measured it. So this is, I think, the better way of measuring, and from the bottom portion of the right coronary artery to here, rather than looking at coronary heights from the top of the coronary artery, because you might overestimate the coronary artery heights. So the same thing can be done in on 3D TEE, but 3D TEE, as I said, it is all individual operator dependent very much. So. And even you're looking at, he can also analyze the sinus of Valsalva STJ, because if these are small, there is a problem with the leaflet sequestrations, and especially in valve or even native bicuspid valves, and causing malperfusion of the coronary arteries or coronary obstructions. And so to pay attention to the height of the leaflets as well. You can measure the leaflet length, and if that actually is going to be longer than the coronary heights, that is a marker for coronary obstruction as well. How about aortic? And if the narrow STJ is very narrow, there is a risk of root ruptures that you can cause damage, and aortic hematomas, and all of them can be seen. So placing a virtual valve ring size here, and you can see whether that actually your ring is outside the STJ, that means it is going to be a problem. You might have to choose a smaller valve than what actually it's on the CT analysis shows that if this is a 23 valve and if it is outside, that means there is a risk of rupture. So you might as well use a self-expandable valve rather than a balloon expandable valve in such a case. So the leaflet length and calcification and the bulkiness, you can actually calculate on the CT scan how thick this or what's the calcium score of the aortic valve is. And at our institution, based on the aortic valve calcium, if it is more than 2000, we protect do cerebral embolic protection with the Sentinel device, and we also do a balloon valvuloplasty before doing a valve deployment. We don't do routine balloon valvuloplasties on every patient, but depending upon whether it is a large valve or a bicuspid valve or a valve calcium score of more than 2000. So that can be analyzed very well on the CT scan, and also bicuspid aortic valve, which you are normally seeing in large numbers in India. You can classify them into bicuspid 0, type 1, type 2. And so I think it is a majority of the patients are the bicommissural rapid type. 55% of them fall into that category where there's a fusion of the coronary cusp. And non-rapid type is 21.1%, and tricommissural is usually about 23% in these people. So the calcium is very important, as we see that, because if there is one leaflet, non-commissural cusp is calcified or the leaflet is calcified, the valve will go to the opposite side. And so you can expect that there will be PVL. So when, for example, if I look at this patient, I will say that, okay, the left cusp is more calcified, and I will have some paravalvular leak. And, I tell the patients that we will have some PVL, and we'll see how we can manage it. If you expect too much of PVL, I think it's better to go for surgery, and especially low-risk patients. These are the categories that we look at. And you can look at the landing zone of calcium. If there's too much of LVOT or anterior mitral leaflet calcification, as you see, aortomitral curtain, and that actually is a risk factor for fracturing that aortomitral mitral angle and causing more damage to the mitral leaflet. So in that type of patient, like these patients, probably better to choose again self-expandable valves. So these are the analysis that we do. We don't have just every patient should get a balloon expandable valve or every patient should get a self-expandable valve. We look at all these echo as well as CT and then decide. So here, this patient has a posterior annular calcification. That may not really make any big deal into our calculations or our choice of the valve. And so I think LV function and the severity of aortic regurgitation also is important. And we don't really bother so much about AI. People who already have AI will tolerate some PVL. That's actually one of the things that only reason that I look at it. But the LV function, if the LVEF is so bad, then pacing it to 180 beats per minute with the balloon expandable valve for too long might be detrimental to the patient. So you can choose a self-expandable valve and pace only at 100 beats per minute. And osteo of the coronary arteries, coronary heights, as we talked about here, the coronary heights are like, I think 18 and 23, I think 21. So these coronary heights are okay on the left side and the right side. And I think so anything less than 12 is a risk factor for coronary obstruction, and especially when you're starting off. So you can still do, less than 8 or even in people with lower coronary heights, but be careful, maybe put in a guideliner and a wire and a guideliner. I don't put a stent anymore. And so the guideliner is deep into the coronary artery, and then we can pull it back and place a stent easily. So a low flow, paradoxical low flow, low gradient aortic stenosis patients are also are missed a lot. And these are the patients that you should pay attention to and bring them back for analysis, or actually look at the valve calcium score and If the calcium score is more than 2,000 in men and 1,200 in women, we go ahead and do a TAVR in these patients with a paradoxical low flow, low gradient aortic stenosis. So people in the true low flow, low gradient aortic stenosis, you can give a dobutamine to see how actually it improves. You hear the peak velocities go from 3.2 to 4.2 meters per second, and stroke volume index is slightly increased. So this patient meets the criteria for a TAVR. So either dobutamine or aortic valve calcium score is what we recommend in these patients. So even TAVR has been shown that it is better to do TAVR in even people who do not have contractile reserve, but the number of patients with that is actually still very low. So, but it is useful, and the number of, it's only 60 and 34 patients, so it's a small study. However, there's further research that is going on to understanding people with the paradoxical low flow, low gradient aortic stenosis, or even moderate aortic stenosis who have LV failure signs by echo or by elevation of NT-proBNP. And so those are all in the research. So I think if there's anywhere, whenever you see any discordant, I think go for calcium score and aortic valve calcium score, and basing on that, I think you can proceed with the TAVR, and those patients will feel better. So this is the flow chart that you might have seen in several places where you, depending on the echocardiographic criteria, you decide on whether high gradient severe aortic stenosis or normal flow low gradient aortic stenosis or a true low flow low gradient aortic stenosis. And so that is where we can, depending on dobutamine, we can further make an assessment or a contrast, non-contrast multi-detector CT scan. So during TAVR, and I think, TEE is very useful to help out where the position of the valve is, and it is coaxial or not coaxial, as you see in these two pictures, and you can adjust based on pulling or pushing the wire back and forth, and you can see that. And the other important thing is horizontal aortas can be actually calculated by this aortic root angle, and it's very helpful in deciding which valve type that you need to use in those patients with the horizontal aorta. I prefer actually a balloon expandable valve, so as you can dilute, you can really make a lot of flexion and be safe in that one, and place the valve successfully. The other my issue is also coplanar angle or cusp overlap angle, and that can be analyzed on the CT scan to understand which angle of the C-arm that you need to place in having during the valve deployment. That is also given by the CT analysis. And so this is actually, you can see on 3D very nicely, it is shown that a perfect deployment can be seen. And so that's actually very nice, and you can deploy it well on the CT scan, on the TE guidance, and it is very clear. In view of time, I think I'll go a little bit faster. And using hemodynamics is very important. So not just echo or fluoroscopy, but hemodynamics are also important to understand whether you're successful or not. And I do not actually further balloon dilate for AI unless that diastolic pressures are less than 40. Between 40 to 60, I just wait for a little bit of time and see if it improves. And if it doesn't improve, then I post-dilate those patients. And detecting complications, I think I'll this is immediately post-TAVR, patient becomes hypotensive. You can see that there is a pericardial effusion, and you know that there is an issue here, and you have to look at all these features of PVL as well. That or LV starts dilating, or there is LV wall motion abnormality. So we'll talk about these complications in the next presentation of mine. And some people can use cardiac magnetic resonance imaging in people who have a chronic kidney disease, and we have done that. That also, but very rarely we need to use that, I think. And so in other things, that there's a patient of us who had a thrombosis of TAVR. This can be analyzed either by CT or by TE, and you can see that there is a thickening of the valve leaflet, And this is called the hypoattenuated leaflet motion or leaflet thickening, HALT or HAM. And for that, the treatment is warfarin for 3 months to 6 months, and we'll repeat it again and to see if that has become much better or not. So HALT is a leaflet, hypoattenuated leaflet thickening. And I think in view of time, the CT aortic valve in valve planning and simulation also can be done. And you are measuring the valve to coronary artery, the virtual valve, VTC, valve to coronary distance. And if anything is more than 4, you're safe that you don't have to worry about coronary obstruction in this patient. So I think that's very good. And so these are the people that we analyze, and alignment versus misalignment of the valve based on where the commissures come. So here are the valve commissures, the TAVR valve commissures, and this is the coronary artery. And if the coronary artery is between 2 commissures, it is safe. Whereas here, this is a misalignment. And the next time you want to get into the coronary artery, it's going to be very difficult because of these commissural are against the coronary artery ostia. So in conclusion, pre-TAVR imaging has to be done with using a CT for anatomy and echo for function. And low flow, low gradient aortic stenosis, you can use CT for calcium score of the aortic valve. And in bicuspid aortic valve, the CT scans are very useful in understanding whether you should do a TAVR in such patients or not. And during TAVR, obviously, we depend upon a lot on fluoroscopy and, and post-TAVR echo. In low-risk patients, you can go with the transthoracic echo, but in high-risk patients, then you're probably better off using a TEE. And sometimes if HALT or HAM are suspected, multi-detector CT scans are useful. And very rarely, CMR is being done for people to evaluate PVL or actually pre-planning wise in CKD patients. Okay. So imaging is an integral part of TAVR. Multimodality imaging can stratify patients. I think with that, I'll stop here and I'll be happy to take any further questions.
Thank you, Ramesh, for covering up this topic also. If you have any doubts on CT imaging or something on echo, you can feel free to ask. Otherwise, we'll go on to your complication talk, where then you can make it ready. Then we'll discuss at the end of the session. Anybody who wants to ask anything about CT or TE imaging, anything? I think it's a good practice for all of us to learn CTs also, though radiologists and the companies give the report. Ourselves should get into the habit of seeing CTs, start practicing it. As Ramesh mentioned, the Trimensho is by licensed software, but you have free softwares available, Orsiro, and you also have EndoViz is another software. Even some of the hospital EchoPack systems also, you can, if you're not all the measurements, but most of the measurements can be done, even our EchoPack systems, which are there in the hospitals too. I think you start practicing it, you'll attain perfection for a period of time in that. With this, I think I request you to go on to this. He has very interesting complications, which all of us should try and prevent, avoid, and learn from those mistakes. And if I heard this talk, I requested him to cover this topic again for you. I think over to you, Ramesh, for the complications talk. Thank you.
Yeah, thank you very much, Dr. Srinivas Kumar again. So yes, the more we do, obviously, the complications you will have. And we started off doing, I personally started doing TAVR since 2009. And so in those days, the 24 French sheets were being used. So there were so many complications that we have seen. And the most common complications are, I think, we are very much worried about a stroke, valve embolization, annular rupture, coronary obstruction, and conduction disorders, paravalvular leaks, vascular complications, and tamponade VSD. Unfortunately, I have to say that I've seen each and every complication that is listed here. And what can we do to prevent them? I think, as we talked about, imaging is very important. And as Dr. Ranga Reddy spoke about how to reduce vascular complications by using ultrasound-guided puncture and making sure the pacemaker is in a good position. There's a debate about balloon-tipped pacemaker, whether the balloon should be inflated or balloon should be deflated. The risk of balloon being inflated is that you might lose capture. The risk of balloon deflated and is that you may be deep and cause a pacemaker or RV perforation. And actually, just 2 months ago, I had an RV perforation in the same manner. So actually, it's not a regular pacemaker. We were trying to do an HV interval study at the same time with the EP catheter, and that caused a perforation. So there are other ways and to tackle the complications. Some of the complications used to be specific to the valves. This is a Lotus valve, not available anymore because of complications, which even though I had no complication, other people had. This is a direct flow valve that is not available. So sometimes we can see only fewer valves, which is a balloon expandable valve, that is my valve or Edward Sapien valves, and self-expandable valves, which we have in India. You have Hydra, and from other countries, especially US, you have Evolute type of valves from or a Portico, Navator, or Accurate Neo. So other new valves which will be coming to address some of the complications are these, Yana valve and Centera and Venus valve, mainly meant to see whether coronary flows will be better. So the all-cause mortality at 1 year with any of these towers has come down to about nearly 7% or even 5% now. But still, PVL can be a problem, and to treat PVL, we increase the density of the skirt in the bottom portion of the valve, where it actually engages the annulus. And but because of that, the deeper you place, the risk of compressing the membranous septum is there, and you can actually create a heart block on that one. So knowing the length of the membranous septum is important, and don't go beyond that in placing the valve. And the new permanent pacemaker is still in the United States. This is considered as a complication. And even though it may or may not be causing extra cost to the patient or to the industry, I mean, or to the hospital, but it is still looked up on as a complication. And still at 1 year, even in partner 3 data, pacemaker rates are about 13%. I know individually some people claim it is 2% or 3%. Actually, at our institution, we look at that. And the last time I looked at is our complications of pacemakers are about 7%, which is still high in my opinion. Stroke, unfortunately, you cannot realize or recognize them early on, and sometimes it can happen much later on. And whatever it is, I think it is related to the procedure, whether it happens in the beginning or much later on, because we might have flicked off some calcium, and it might have been hanging around for some time, and later on, after a few days, it might go and cause a stroke, or atrial fibrillation obviously can be non-procedural and cause a stroke as well. So in the beginning, when we didn't have anything, we used to do these carotid pressures at the time of advancing the sheath or valve deployment. And we have to be very careful with manipulations and minimize post-dilations. And if the patient has carotid disease, whether we should pre-treat. And then we have this Sentinel device, which are, other devices are still investigational, and Sentinel device is important. So, but let me show you a complication. 81-year-old patient undergoing TAVR. We did iotogram, and then we are advancing the Sapien XT valve. And probably somebody might have seen here, there is something that I'm dragging in the aorta. So when you look at CT scan, just don't look at only the annular measurements in the ascending aorta, but also look at atheroma in the descending aorta. And we don't actually do any more of these type of TAVRs transfemorally if I see a atheroma like this. So I'm dragging an atheroma, as you can see here, along with the valve, so that's an atheroma, calcified, okay? So what happens, I saw that, and then I stopped and I said, what should we do? And I said, there's nothing else we can do, so here is the atheroma that is coming. And it went around. So we saw that, what is that flap, so it's such a big flap that is coming out. So the cardiac surgeon, we decided, okay, unfortunately, we just have to go ahead and do it now. We can't do anything about it because at that time, there was no devices available. So we went ahead and deployed, and then we pulled back, and you'll see that actually the calcification of the atheroma plaque is also coming back. But it came back until where the sheath is, and then it actually dislodged and caused occlusion of the femoral artery. So that's one point. And so this is the risk of strokes can be, I mean, are less, but it is still, can be anywhere from 1 to 2%. And I think, we are immediately hemorrhagic or TIA. Most of them are actually ischemic strokes. And this patient 2 days later had agitation. So we did an MRI and it showed multiple foci of ischemic strokes, and patient ultimately died from that actually. And so sentinel devices is what we use in these patients nowadays, or actually a bot doing it from transfemoral and take it out. And I think that's what I should have done in that patient. When I saw it going into the arch, I should have just stopped it there and taken it out and canceled the procedure and brought the patient back from a transcarotid. That's what I would do currently. So this is a Sentinel device. The data, Sentinel ID's data is not really great. This not been shown to be better than control. But that said, the secondary endpoint of major disabling strokes are lower with the Sentinel device rather than not. So in younger patients, high calcium score, where we're going to do balloon valvuloplasties and or bicuspid valves, we do use a Sentinel device in those type of patients. It's extra cost. This is an 86-year-old woman who's mother of my research nurse, and at that time, valve was not approved. We had to wait for it to get approved by FDA. Sapien XT valve was placed, and while placing the Sapien XT valve, if you look at it closely again, we are inflating and inflating and inflating. And normally we wait for 5 seconds. So, but within, see, as you can see, we didn't wait for 5 seconds. So the balloon has to be expanded and we count up to 5. And here again, look at it. And now it's inflated. Now I'll start counting 5, 4, and it actually deflated already. So what happened here was actually the balloon ruptured. And when the balloon ruptured, again, we didn't know what to do because we never had anything like that. And we called surgeons and vascular surgeons to come. And they said, it's okay, just pull it back. And I shouldn't have done it. And I pulled it back. As you can see, the balloon starts unfolding. And it entirely scraped the aorta and the iliac arteries and caused huge damage. And in fact, she died on the table. So what did they do? This is part of the iliac artery and aorta that came out. And what it did was basically this is stuck over there, some of the material of the aortic aorta. And here, this is what happened. This is like an umbrella. And if you feel this balloon, you'll see why you should not drag it down. And it is really stiff, these balloons, So this is a balloon expandable valve, and the balloon is very stiff. And it's like an umbrella, open umbrella, and dragging down into the aorta. That's how I feel. I describe that. Okay. Unfortunate event that patient died. Okay. And oversizing of valves and balloon expandable valves are not advised anymore, about 20% because of these complications that we had. And in addition to calcifications and or annulus eccentricity or eccentric calcium, and heavy, aggressive post-dilation of these balloon expandable valves or self-expandable valves can cause damage. So using self-expandable valves is much better in these type of patients. So here is a heavily calcified eccentricity is not that bad. Oversizing of 12%, and original Sapien valve is being deployed. And as you can see, it looks like it's coming out of the aortic size, So that's an unfortunate event that it has happened. The patient becomes hypotensive, pericardial effusion, and you can see the shadow there. And then we put a pigtail and options of valve-in-valve or surgery. And so those are the only 2 options. This patient actually had a surgery at that time. And still at the end of the day, after a couple of days, she passed away. Conduction disorders, we talked about that. And here the patient with oversizing was 10% severely calcified. And, there's a fracture of the native leaflets overhanging above the processes. And so that actually caused a severe PVL in this patient, mild to moderate PVL in this patient. And that's a risk factor that you can treat it with another plug or another valve, so that's a decision that you have to make. Coronary obstruction, but now the PVL rates have come down because of the skirt changes on the skirt that have been made. So coronary obstruction, I'll just show you this valve in valve, and you need to understand the height of the coronary arteries. And there's already a stent that has been placed. That's how we used to do in the beginning. And so we suspected that, and the patient becomes hypotensive, severe ST depressions, and so we pulled back that stent and placed it in the left main, and so that patient actually did much better. And so after placing the stent in the left main, patient recovers completely. Okay, so watch out for EKG changes, hypotension, and wall motion abnormalities immediately. And so the 30-day mortality with coronary obstruction is very, very bad if you are unsuccessful to do a PCI, and it's about 50% mortality. So unfortunately, we had one patient who passed away after a couple of, within 30 days after not able to open up the coronary, left main coronary artery successfully. We opened it up, but not really greatly. So risk factors, small aortic root, and coronary heights less than 12 are the risk factors, and valve to coronary ratio of distance less than 3 millimeters is also less than 4. Be cautious, less than 3, absolutely worry about it. So I think small annulus, I think we'll say it can cause increased residual gradients. So here is balloon fracturing. So sometimes you have to go 16 atmospheres. And so this fracture. So the balloon valve fracture can reduce the gradients from 19 to 8, as you can see in these patients. So hypotension at any time, you can worry about sheath insertion, peripheral artery perforation, and you have to look at early angiography. After stiff wire has been passed, worry about severe MR or tamponade, and post balloon valvuloplasty, again, severe AR or tamponade, and check with an iotogram. And post valve deployment, these are the ones that we discussed about an annular rupture to coronary occlusion and severe AR, usually the ones that are causing problems. So in short, actually patient selection and increased operator experience and improved devices technology are key to prevent complications. And pre-TAVR imaging is very crucial. And adjunctive techniques that will help you to control and manage catastrophic situations have to be learned. And it's not easy to access the coronary arteries in self-expandable valves when you have an obstruction. So it's always better to protect. And learning basilica for people with valve in valve or low coronary heights and narrow SDJs, I think is also very crucial. So the new ways of protecting the coronary arteries is important. And ultimately, heart team with knowledgeable and complementary members is important. And offering TAVR in low-risk patients, such as young low-risk patients, I think is not a good idea. I would recommend surgery in those patients. Thank you very much. I'll stop here.
Thank you, Dr. Ramesh, for covering up and showing some of the interesting complications which some of the doctors sitting here would have never seen, and hope they will not see also. So we can learn from others. We can learn from others' mistakes. That's the idea of asking him to present. And thank you again for showing it very clearly and explaining to all the doctors. Any doubts you have, because Ramesh might have to leave. If any of you want to ask any doubts to him, you can ask now. Otherwise, I will present my talk, then we'll break for coffee. Any of you who wants to ask not only on complications, anything related to TAVR also, you'll be happy to take questions.
Yeah. Thank you. I think it's important for us to just have a dialogue with the patients and as well as with the peers. If you have a doubt about any patients, I'll be happy to look at that and give my opinion as well.
Yeah, many of them have doubts regarding the age of procedures being done for TAVR. They express that some of being done at 60. What are your thoughts? Just can you tell them about selection of patients regarding age?
Yeah, I think obviously in America, people live longer, and maybe in India, we think that they live less than the life expectancy is about 10 years less than Western population. But that said, 60 and low risk is a person I would not recommend TAVR here in India or in America for sure. But if 60 and has a liver cirrhosis, MELD score of 16, and other issues that you can talk about, whether chronic kidney disease, renal failure on dialysis, those are patients who you could still offer TAVR. So we have an in-hospital TAVR mortality risk score, a TAVR risk mortality app. You can look at that. And obviously STS risk mortality. And if the TAVR risk mortality is lower than STS, I will offer them actually TAVR in high-risk patients. But if the STS risk mortality is lower than TAVR, I offer surgery in those patients.
Thank you. We have Dr. Sandeep Bansal sir is professor and head from the Safdarjung Hospital. He was expressing today morning in the ECHO talk that bicuspid aortic valve is off-label indication. We need to be having some special reasons to do it. But I was telling 50% of our patients are bicuspid. So what can you just mention to the young doctors here that what are the special things you look for in a patient who has a bicuspid aortic valve compared to a tricuspid?
Yeah, I mean, absolutely. I think bicuspid valve, we are still doing it. It's off-label, meaning, there's so many procedures that are off-label that we do in interventional cardiology. But that said, if the patient has truly severe bicuspid aortic valve stenosis, look at the leaflet calcification, leaflet length, and with a heavy calcium score. These three are the limiting factors to get a great result with the TAVR, especially if they are low risk. Okay, so taking a 60-year-old patient with bicuspid aortic valve with all these high-risk features, what I told you again, in addition to bulky leaflets, heavy calcium, and eccentric calcium, you're not going to get a good result. In addition to that, aortic root dilation. If they have an aortic root aneurysm, you might actually cause dissections of the aortic root while advancing the valve. And so I think these are the four features. Be cautious and don't recommend young bicuspids to be treated with TAVR.
Thank you, Ramesh, for your
Thank you.
time and clarifying all the doubts and showing the complications effectively. And if there are no further questions, I think if we have other commitments, we can break. I will.
Thank you. Thank you very much.
Thank you.
Thank you.
Can you get these slides, my slides on, please? Before my talk, they want to have some housekeeping announcements. So you can come and do it.
Hi, good morning, doctors. We request you to just scan this QR code mentioned over here, wherein you will be allotted 2 CME credit points as well as the certification. Thank you.
Yeah, I think we're running slightly behind the schedule. I'll try to make up the time. As you have seen the complications before, and it was because Ramesh has to finish it, I requested him to do it, but I would like explain now TAVI basic steps and how to do the procedure. And obviously, if you take all care, we'll avoid the complications. But before that, I wanted to check with you people, how many of you are exposed to TAVR in this hall already in your centers? Can you raise up your hands, please? Yeah. A good number of people are exposed already. That's how the TAVI is becoming very popular after it got approved in our country too. And how many of you are interested to see this? What are the steps and basic things? Because some of you already know it, then you can always avoid some of the things. But hope all of you will learn something. That's why I planned it as a basic talk with step-by-step approach to explain the various steps in TAVR. Hope you all are okay with this. You want to listen to this talk? How many of you want to listen step-by-step talk, or how many of you feel already you're okay? Good. I'm happy at least. If you are in general, I'm telling, if you want to make people say yes, there's a different way of doing it. If you want to say it no, you can different way of doing it. Anyway, I'm happy either way. Their hands are raised. So I will briefly cover up. I'll take about 5-10 minutes extra time for you to from the coffee break, which you are supposed to have it, and afterwards we'll decrease the coffee break to 15 minutes, and then we can reassemble back for the interesting STEMI sessions and neurointervention sessions. Dr. Sandeep Bansal sir, the senior most professor, is waiting to interact with us on STEMI. But before that, I will take you through the step-by-step approach in TAVI. Then this slide, again, I always keep showing this in hub and spoke models, always get to work as a team, and especially in tough times of COVID. And it's like all our friends working together and identifying patients for TAVR and also helping each other. Work-life balance, everything gets managed very well if you have the team approach. Some of my colleagues who are working in Remedy Aditya are also here, apart from my colleagues who are working in Apollo. We thank all our team members for making my life easy. If I'm able to do all these activities, it is because of active cooperation for all my colleagues. The patients are being taken care of there. As you've seen, I've designed this talk as basic, but we'll try to switch over and run faster in some of the basic steps. But what is TAVR is what is made this cartoon for a press actually, where the native valve is being replaced by the self-expanding or balloon expandable valve. I'm extremely thankful to partnership between FACS and Columbia Heart Valve Therapy Unit, especially Dr. Sushil Kodali here, apart from Martin Lee and Ajay, who always support, because they were always stood as a rock. And before pre-COVID, a good friend came here and handled us. And in this part of therapy, when this therapy had some complications, it didn't pick up. But once he came and we did the procedures carefully, about doing 40-50 procedures without much of complications, then in and around all the hospitals in Hyderabad also got confidence, and that's how we learned this technique. And the beauty of this man is he treats patients as their own relatives and take all care to prevent complications. In the era where you had complications, once we did 50 procedures without any complication, that's how everybody got confidence in Hyderabad at least, and in and around. That's how the valve therapy program picked up. And we also learned around, so to learn some of the important techniques, went around Italy, went around Amsterdam to some other techniques. In these centers, they were very aggressive doing coronary and TAVR together within 1 hour. That's how we got more and more confident. And I've learned this heart team concept in this Heartland Swiss clinic. It is a really heart team. They all sit together, discuss, and decide which patients needs to go for surgery, which patient needs to go for TAVR. That's very important, which all of us can emulate and follow. I'm extremely thankful to my good friend, Dr. Samir Kapadia. He's now become the chairman of Cleveland Clinic, where it was our luck to go there because of him. Initially, we used to think that listen of it's a great, but we had opportunity to go through and stop for some cases there. This is a hybrid cath lab which they have, and they follow the single femoral artery technique, which we learned from them. So it is good to know. And the Cleveland University opposite is Dr. Atizani here is pioneered this technique of decreasing cuspal overlap view, where they were decreasing the complications of temporary pacemaker, but always a good friend and explains to us for any help. Also very thankful to all the colleagues across, especially SGPGF friends across the country, who have been referring patients for us to do these procedures. That's how the Apollo also was happy. It was in news where we did 5 procedures together in a single day before. And the institution support is also very important. We have a hybrid cath lab, which is nearer to OT, though sometimes luckily now we don't need, but the facilities are also important. We have some softwares where the CT gets imposed onto the cath lab, helps at least in early learning phases to avoid complications. Now that you become more comfortable, you don't need to do all this, but the sort of superimposition will make us comfortable. And if you feel that sometimes this valve is not expanded there, with this, you get more confidence to do post-dilatations and see that the valve expands well and avoid complications. So technology helps us, apart from the heart team and colleagues, to avoid complications in between. So I actually made some videos also for you as a live in case box, but for sake of time, I'll skip. I was basically explaining, my colleague, Dr. Gokul Reddy is here, a surgeon also here, and a cardiac anesthetist. The real heart team, it is there in the hospital, it is in the hospital, it is better. So This is a 81-year-old doctor. See the patients nowadays. Our patients also simulate West. He is post-CABG. He has now developed severe aortic stenosis, presented with LVF. Such sort of patients, actually, this therapy comes as a boon. Narrow QRS, but old antiseptal MI, echo, severe calcific aortic stenosis, and LV was reasonable, but then pre-op evaluation by echo is already covered in detail. I won't want to go into it, but evaluating whether it is tricuspid, bicuspid becomes important because we have some particular precautions we will follow, especially if there are bicuspid aortic valves, which I already told before. Doppler gradients assessment in symptomatic patient, it may not matter much. But once it crosses 4 meters, but in asymptomatic patients, we need to be careful in assessing. This is what I was mentioning. The CT TAVR protocols, all of us should become very comfortable with it. At least practice this short axis views. We are not comfortable, but if you keep seeing it daily, then probably you'll get into that. So where you normally also see this is a pulmonary artery, then bifurcation sometimes for the pulmonary thromboembolism, which we are very comfortable. Why we're not comfortable is at the lower level. This all we can make out easily. Femoral artery levels, we are not very comfortable. I think that's how you keep practicing it, you'll get it. But we are okay with these long axis views because we generally see it in cath lab like this. Radiologists are seeing the short axis views. The long axis views, again, putting the proper analysis, proper resolution is important. The CT report analysis already told in detail by Dr. Ramesh just now. It's important to have the coronary heights in mind. This femoral artery evaluation was covered by Ranga. This is what I was mentioning. If the gain settings are not right, you will miss the calcifications. We were not comfortable before. We missed this sort of deep calcifications when the gain settings were kept very high like this. So it's important to work with these radiology colleagues where they know the gain settings, other things better, but image interpretations, narrowings, we can interpret better. That's why combinedly, I feel we can always do a good job. That sort of calcifications by proper gain settings could not be missed. As is already shown, Ranga has already told us about ultrasound guidance. We have handheld devices like this, which have come, which is very useful. We need not carry the full machine here. Nowadays, we try to use this. If possible, you have a bigger machine, it's fine. Otherwise, those handheld devices will be also useful. And you check a femoral artery, both by cine as well as ultrasound-based punctures. If you are comfortable with, you can use it. And ultrasound-based thing which is shown by Ranga will help you to directly puncture the anterior part of the artery. But basically, there's no big deal in it. What we have learned right from my student days, that's the same thing what we are supposed to do. What we are doing is, basically, you are striking the common femoral artery, avoiding going down below the bifurcation or avoiding going very high up. Because if you go very high up, you get retroperitoneal hematomas and complications. You can't control the bleeding. If you come down, because these arteries will become smaller, these will need at least 5 mm vessels. So we need to target right on the head there. That's what basic femoral artery technique is. There's nothing new in this. So you need not get worried, perplexed, what is new happening in this large bore axis. It is basically the standard teaching, which is there ever since 1960s, is what is being re-emphasized now for you to practice. And you need not get so much puzzled by what is there in axis. But it's very important. All of us should take time and do this puncture properly, because most of the complications happen with the vascular axis only. Once this is done, rest of the procedure nowadays with more and more expertise, it's done faster. But even today, we should give maximum time to this. This video, I made it, actually sound is not coming, I think it's okay. Basically to show the two one arterial axis, one venous axis on the left side, and then on the right side, we use it to take the valve inside. So this video basically shows that. Then I also recorded in the cath lab how the valve is being taken inside. Once you dilate with the dilators, once you put the sheath, see initial struggle at the calcification, sometimes it could be there. But again, with proper coordination with the wire and this, you take the sheath dilator inside. Then this is the steps of valve preparation. Basically, the therapy specialists from the company help us to prepare the valve in the lab, because it has to be done immediately. Then once that is done, once this is being taken in, once the dilatation is done, before that you cross the valve with this. You are comfortable with, we generally use thermo wire to cross the valve. Once the valve is crossed, we take it deep inside, exchange that with a pigtail catheter, and place this extra stiff safari wire or underquist wire, whichever we use it regularly, and exchange over the pigtail. The idea is again to keep the stiffer wire with a looped way so that it doesn't, the stiff portion doesn't injure the myocardium. That is the basic principle in it. And you form a loop and you should avoid the entrance of cardia through mitral cardia. Also, sometimes it could create trouble. And see, one pigtail is kept in the aortic root. The other one, stiffer one, is taken inside the left ventricle, and the valve is being threaded on with this thing. Then take it properly, and once you get across, this pigtail will also act as a landmark for us for the baseline lowest sinus, and then maybe 1/2 diamond below it and 3 mm below that. Nowadays, we want to come closer to annulus as possible. And you check with aortic root angio. Once you are comfortable with this, then probably that's where we tend to pace faster. Why we pace fast rate is we want the cardiac output to fall and the pressure should not fluctuate. Otherwise, each systole, the valve gets ejected out. So if you pace it, the ejection will be less, and the valve movements will be less. That's how the pacing is done when you are expanding the valve. Once you're comfortable with it, then probably at the last point, till 80% release also you can check, and you have the methods to capture it back in self-expanding valve. And then once you're comfortable, then you can release the valve. Once the valve is released, then the control is lost. But by and large, once you're getting this nose cone out also, you need to be careful. Sometimes this can get stuck across one of those leaflets, those valve things, and it can get back. So be careful while taking it out also. Once it is done, then probably we check the gradients again, the LV aorta, and then before gradients were there, now there is no gradient. Check the aortic root injection, there is no AR and no gradient. That's a good result. This is the final aortic root. After checking this, no leak into the AR and no parallel leaks. We also check on the echo also. And see, final check angio, the femoral artery is mandatory. After closure devices, again, sometimes you could develop constriction there, or sometimes a mild narrowings, which might need balloon appositions and dilatation sometime. So after putting the vascular closure device, which Ranga has already shown, we always check a final check angio. I think why this technology is becoming popular, especially balloon expandable valves, is basically stent-like. We are all comfortable expanding the with stents the same way that you can expand these valves. That's how this has become very popular. And this patient whom I have shown, they did not develop any blocks. That is, the procedure is done. And pre-discharge echo and post-discharge echo. Sometimes we have patients who have LV dysfunction. Also, their LVs improve dramatically even before discharge itself. This man didn't have too much of a problem, but we have seen some patients where LV dysfunctions improved and the creatinines also improved in subsets. This had various subsets. Not only inoperable high-risk subset cases, but we did cases of all these nature, elderly patients, severe LV dysfunction, CKDs with very minimal contrast. Their creatinines also improved post-procedure because cardiac output improves and it helps in better kidney perfusion. But take care not to inject too much higher contrast. The porcelain aorta, where surgeons were worried to put a graft or take incisions there, also was done. Bioprosthetic valve degenerations, valve in valve, that is being done commonly because patients will be worried to go for second procedure after the bad experience of the first surgery. And patients had bioprosthetic mitral valves. The coming again for aortic valve disease now happens sometimes also we have done. And bicuspid aortic valves again, which offline indication, but 30% of the time, 40% of the times, most of them are bicuspid. Sometimes they're associated ARs, there's no problem. We also seen associated mild, moderate regurgitations, mitral regurgitations also regressing after doing TAVR. That's why the latest TAVR classification, apart from the Eugene Braunwald, what is exertional triad symptoms. Now, what is latest is request all the residents to go through it. They might ask in the question exam also. Now they have separate classification of aortic stenosis. You grade them into 5, say, depending upon the back pressure changes of the aorta from the heart structures. Aortic, only LV is involved, LV, LA is involved. Again, right ventricle is involved. Pulmonary arterial hypertension developments and all that. Finally, TR and atria are also dilated. That's the worst. So you have those subsets of patients, but all of them will regress if you tackle this patients with TAVR. So that's how the TAVR revolutionized, and especially the imaging multimodality concepts have helped in these patients. And we are all wanting to do this because our patient, this lady was referred from Nagpur, was sick, not able to lie down fast, went to vote. That's how that gives happiness that we save this patient. The sick patients become active and lead a normal life. With this, I'll stop and I thank all of you for making this TCT India successful in Mumbai last year. And July 26, 27, 28, 2024, we are doing it here in HICC. And Lupin promised us, all of us who are interested, if you can get back to them, they will get you there also. Thank you again. I finished, I think, in 15 minutes. I'll be happy to take any questions. Otherwise, we'll break for tea. Thank you. Sorry. Not only this, any other doubts we have in TAVR, or because now we'll close the session of TAVR and we'll go to STEMI sessions. You can ask freely any doubts which you have. I tried to show various steps and tried to stimulate your thought process, and then probably showed some complications what we can avoid. And but in future, all of you should learn this technology, because it's likely to come. More and more patients are likely to get benefited, and interventional cardiologists are also smart. Once they become perfect with that procedure, there are more indications will also start coming up. The new research is also coming up. Martelnia now proposes the concept of upstream therapy of aortic stenosis, where you need not wait till it becomes severe, and then even the moderate aortic stenosis subsets, which are likely to benefit by the procedures, are also being explored. Now we are also reaching an era where we are able to tackle this severe AR patients also. We have JenaValve, which is launched, which is only for isolated ARs also being done. Apart from AS and AR, we anyway do it, but isolated ARs also, we are almost coming to the clinical research phase. And that's why it's important for all of you to understand the concepts and do what is right to the patient. But one thing is, if you have any contraindications for the TAVR procedure, I'm not nowadays too much worried whether the patient is high risk, low risk, or moderate risk, because in all the subgroups of patients, TAVR is found to be useful. But you have to see whether any particular contraindications for doing a TAVR procedure. That's what is most important. The most important contraindication at this stage, I feel, is doing it in younger patients. We don't have data of more than 10 years. In future, the valves which last longer come, and then probably more studies come up in younger solutions, we might do it. But as of now, as Ramesh mentioned, please don't advocate this therapy for anybody who is less than 60, unless I think we did 2 patients in less than 60 years. One was severe L dysfunction, CKD, where surgeon was not willing to touch, and very high risk. That is a life-saving procedure is different. But by and large, you should avoid doing these procedures in less than 60, that is age. Number 2, if you have any contraindication, specifically, you know that this may not be doing well for TAVR. Just because patient comes to you for TAVR, it's not your prestige that you have to do it. I'm never comfortable with this phenomena of low coronary heights, where you know that patients likely to get into trouble with coronary obstruction on table. People do this business of coronary chimneys, putting stents in the left main and doing TAVR. Then that is, if a patient is totally unfit for surgery, is different. But in low risk patients, please don't plan such crazy therapies. And this, whatever data we have in comparison of transfemoral versus surgical AVR, is only transfemoral. Again, crazy stuffs like going from IVC, going from other access, again, is not proven. In a surgically unfit patient is different. But if patient is fit enough, and our surgeons also do a good job, you can still send the patients for surgery if required. That's where the heart team approach comes. On the other hand, if a patient of redo surgery goes to a surgeon, unfortunately, some surgeons who are not very comfortable, don't have a heart team, they try to do redo surgery. That's also not right, because redo surgery will be having higher risk, especially when the patient is 70 years plus. So you should avoid that also, and try to do what is good for the patients always, irrespective of the fact whether the patient comes to a surgeon or a cardiologist. I think with this, I wanted to stop here, unless you have any questions.
Severe AR without much molar calcium. Is there any role for TAVR in these patients? Patient is high risk, elderly, but predominant AR.
Yeah, that's what I was just telling. Generally, calcium helps to anchor these valves. So the calcium which is there helps us valves, preventing valve pop-outs and proper positioning of the valve lift. In isolated AR patients where there's not much of calcium, that's where people are trying to do the JenaValve, which is approved for this purpose, just as an experimental basis and research basis. That's where it has anchors which comes out first. It anchors at the level of sinuses, and then it gradually gets relieved. If you have expertise with that, it is okay. I think that is done with a few 50 patients. The study has come out. It will come into the clinical practice hopefully in 1-2 years. But apart from this, we are not reached a stage where we can advocate this if a patient is fit for surgery. If patient is sick and not fit for surgery, that's a different story. People are doing the balloon expandable valves with 30% of over-dilatations, which was demonstrated in one of the live case in TCT. Martin Leon again figured it out and was led a lot of discussion on it. That is not recommended as of now because it is always could lead to trouble, too much oversizing of the valve because the calcium is not there to anchor. So as of now, if you are expertise and JenaValve comes, I think we can try for doing AR. But otherwise, isolated ARs, we avoid doing as of now today. Yeah.
If there is a discrepancy between the coplanar view given by the 3-Menzio and the fluoroscopy on table, is there any SOP to adjust that? And also, sir, do we routinely have to image the ostium of both coronaries after the valve deployment to document that it is free of obstruction?
Those are two very good questions, actually. He already has exposure to this. I think that's why he's asking the relevant questions. But basically, the coplanar view, what is that view is where you, in the pre-CT also you study all the three sinuses will come in one level so that it avoids a paradox. See in some angle, it looks like it is distorted, and when you're placing the valve also, it looks one lower on one side, other. And to avoid that, all the three sinuses should be same level so that you place the valve just 3 mm below the coplanar view. So previously we are only watching the coplanar view and taking only LA views. But with the advent of this commissural alignment technique where extreme RAOs we are going, that is delineating the membranous septum, which overlapped by the valve is leading to AV blocks. That's what the study shown. That's why this commissural alignment technique came with extreme RAO views. But why we are somehow more comfortable in still the coplanar view, checking in LA view. What we do now is we go to the extreme RAOs and also check in the coplanar view, but we do commissural alignment view, but we also check in coplanar view. And if there is a discrepancy between the CT and the cath lab, we go by what we find in cath lab, because sometimes the patient's positions also will vary during the way CT is acquired. So in cath lab, there could be minimal 10-20 degrees variations, but finally our aim is to see how the sinuses are there on table, because you are deploying the valve on table. So you have to align little angular motion this side, that side will help us to see that you can have a pigtail and image in the aortic root you take and adjust the cath lab positions. If you have a 3D rotational cath lab, it is more easy to see which is the best view. Once you take aortic root in any way, you can see the angulations and fix up one angle where everything falls in one line. Coplanar is one plane, all the three sinuses have to be there. That's it. So if there's a discrepancy, we check in the cath lab and decide. And once you are releasing the valve, especially in self-expanding valve, it becomes relevant. Balloon expandable, anyway, you have less control. Then self-expanding, you see all the other end of the lower limits of the valve structures should be in the same plane. That is, I think, when there's discrepancy, go in what you're finding in cath lab. That is the answer to your first question. Second question, what you were asking was what to check about the coronaries. It's very important to check the coronaries, but indirectly you'll know it. If you produce a problem on coronary, it will declare itself. I had some interesting complications. I gave a talk in Sentient, I had it, where the coronaries get occluded, it will declare itself. Immediately it will present with cardiac shock, a cardiac arrest, hypotension, STT changes. So you know it, that is safe, but as a general protocol practice, we don't do selective, but we take aortic root shot to demonstrate that we are coronary perfusions is all right, and it's mandated to check aortic root angio before you close to document that there's no AR, no paravalvular leak, and also coronary perfusion is well maintained. And you also, in the end, check the femoral arteries. I think that you also get indirect evidence by the patients being stable, and you also check on the echo also if you're comfortable with the echo. But coronary perfusion, as you mentioned, checking is mandatory. Okay, there are no questions. I think we are slightly delayed. We'll reassemble back with a tea break, 15 minutes break. Anything you want to add? Yeah. Felicitation for speaker. Okay, go ahead.
Thank you so much, sir. So now I would invite Dr. B.V. Rangareddy, and Mr. Tapas would felicitate Dr. Reddy. Mr. K.D. Rao, sorry. I would request to please be on the stage. There is one more felicitation to be done. I would request Mr. Jaydeep to do this.
So thank you once again, Dr. Vivek. It's our honor again on behalf of Lupin Digital Health to felicitate Dr. B.V. Rangareddy, who is also a digital pioneer. So for that, I would request Dr. A. Srinivas Kumar sir to come on the dais and our senior leader, Mr. Rohit Monro on the stage to give him the ACC certificate. And as you all know that Lupin Digital Health is the fully owned subsidiary of Lupin, and we are the sole company in collaboration with ACC. So on behalf of ACC, we would like to hand over the certificate of a digital pioneer to Dr. B.V. Rangareddy, whose belief in cardiovascular care, improving the outcome is what drives better outcome.
Yeah. So before we go on to break, I just wanted to make an important announcement to please check out from your rooms because the time is up for the booking. So I would request all of the respected doctors to please check out in this break. Thank you so much. We'll assemble back at 11:45. Thank you.
प्रमोद की changes.
So welcome back all. Next, we are going to have this session on STEMI. This would be chaired by Dr. Sandeep Bansal, sir. To start with the first topic, STEMI with complex coronary anatomy, I would request Dr. Srinivas Kumar, sir, to please start the proceedings for this session.
Good morning, and this is a very important session because ST elevation MI, as we all know, forms bread and butter for most of our cardiology practice. It's the largest contributor to cardiology practice of the general practitioner. And so I have the pleasure of inviting Dr. A. Srinivas Kumar to tell us about STEMI with the complex coronary anatomy and how to go about making decisions in that scenario. Dr. Srinivas.
Thank you, sir. I think as others are accumulating, I thought I'll just finish off my talk, and then all of us, once we come back and listen to Dr. Sandeep Bansal. So we have designed it that a little like early presentation within 12 hours or multivessel disease and delayed presentation. The second aspect will be covered by Dr. Sandeep Bansal, sir. This was supposed to be given by Rishi. I'm filling it up because he had to leave with some urgent work. So I put some slides together. Excuse me for that. And what I would like to briefly discuss is tell you about some of the guidelines which are very important. It's always important for us to understand how these guideline recommendations evolve also. And there is science in it. And then initially what we thought correct would be proven wrong, and exactly opposite could come out in 2021. So initially we used to think that only culprit should be done. Then they said complete has to be done. There complete also some exceptions are there now in cardiogenic shock scenario, which I will touch upon in the 2021. This actually came as chest pain guidelines, but part of it is STEMI guidelines. Then show you some case scenarios to make it interesting, and then show some places where we could save patients, and also a little more in detail on the decision making of multivessel disease in these patients when they present with acute MI. And then this 2017 guidelines is very important in the sense that it has thrown us some important new things. Always, though we were doing radial arteries before, but in acute MIs, we were initially not doing radial punctures because it was we thought that in those days will take more time. But in this trial, it clearly showed if it has to, one thing which has made a lot of difference is radial access, where the complications related to femoral artery, especially in the pharmaco-invasive strategy era, where the streptokinase or the lytic therapies which are given, once you did femoral, a lot of complications used to happen. Those all are gone. So that's why radial access became the therapy of choice and class 1 indication in acute MI. So most of the centers have adopted this, but any of you who have not adopted the change to radial, please do it, because that is class 1 indication, the top indication in 2017. So if a patient of acute MI comes, please do take up patient for radial access only, unless there is some particular problem where you're not able to do it. And this era, some controversies were there in 2012 before. People were arguing that DS will reduce to complications like SAT and things like that. On the other hand, now various trials which are written here show that probably DES is preferable even in acute MI scenarios. So there's no more discussion on it. So like how there is radial, no more discussion. I think none of us should have any doubts, and we hardly practice this. No, bare metal stents are not on shelf also in some hospitals, rightly so. So DES is the treatment of choice even in that. And complete revascularization, which was thought to be red because it was creating trouble, that is class 3, now again changed to class 2A indication with some of the new data coming up. And then thrombus aspiration, yesterday one young doctor was asking, it is well, IABP is class 3, why are you using? Similarly, the thrombus aspiration also became class 3 total test. But all of us understand this decision has to be individualized. When the patient comes very late, we choose thrombus burdens. We have done everything with the balloons. It doesn't work sometimes. If you put a thrombectomy catheter and suck it, then a lot of times the thrombus comes back. And especially in the late presenters, I think Sandeep sir would cover it, will be very useful. And then bivaridine, lot of hype before as class 1, now it became class 2A. Same thing with enoxaparin. Whatever you're comfortable with, regular heparin practice is good enough. And we want to do early hospital discharge if possible. Oxygen status did not improve. And pharmacoinvasive strategy is what is picked up, which will be covered in a separate lecture by my colleague, Dr. Ramakrishnan. Additional lipid lowering therapies, we want the lipids to come down as much low as possible. That's where I think not only high dose statins, we take help of ezetimibe, but also PCSK9 inhibitors if required, because even the lower levels of cholesterol are producing trouble in our patients. That's why we want to keep it very low. So in the patients is not an antiplatelets champion trial showed cangular also can be used, but nowadays we door to balloon time generally about 1 hour. So giving ticagrelor in emergencies and switching is also okay. But if you have a single center, some of the doctors are sitting would be owning one your own center where switching happens in 5 minutes. There, I think cangular has a role. You can give a cangular and take up this patient's procedure. And initially, it was worried to use about ticagrelor also. Now it is found to be safe even in lytic patients. But prasugrel generally, unless we see the coronary anatomy, we don't give it. So polypill to increase again adherence is also become important. Class 2B indications. Then some of these timelines, frames, I would skip for the sake of time. But generally, less than 12 hours is what is indicated. This cartoon, I think many of you are favorable, already know about this. This is what is the concept, what is came is patient delays is one which is maximum troubling. But what we need to target is the total ischemic time. The patient coming delay is the predominant problem. That's why patient education is the most important. And once the patient comes to the hospital, we have to do the job as soon as possible. Door to balloon time should be kept in less than 60 minutes if possible. In COVID times, we analyzed our data in Apollo that we wanted to work faster. We were successfully decreased the door to balloon times to 50 minutes, especially this problem of discussion on finances was taking a lot of time. So to remove that, then we removed that discussion on finances. Most of the patients we discussed with the administration also, they would pay. That is not there. Actually, we can do the procedures faster. Nowadays, we don't do balloons in all the patients. That's why the term called, instead of door to balloon, door to wire is what is now introduced in this guidelines. Then this concepts we all know. Then one thing is previously we used to say as rescue PCI when you're giving lytic therapy and then taking of the patient if patient was symptomatic. But now we call it as pharmacoinvasive strategy where after lysis within 2 to 24 hours, we send these patients for routine PCI. That's where it is very ideally suited for an Indian scenario that it will be covered separately. This is what is wire crossing time. The reperfusion, that is what is indicated and should be practiced. All the green ones are class 1A. So I'm talking about only class 1A indication, that means patients presenting less than 12 hours. And ongoing pain or ongoing hemodynamic disturbances, even later, you could take up these patients. But routine in asymptomatic stable patients, we need not do angiogram. But by and large, I would confess in corporate practice, all these patients get subjected to an angiogram and decide whether to do it or not. Depending upon the anatomy which the patient has. If patient has proximal LAD, left main, a very critical blocks in the proximal vessels, you might tend to do it without even studying. But ideal practice says if the distal branch vessel disease, the patient is asymptomatic and leave it. This is where the concept of infarct-related artery and the technique and what to do with the other vessels is going through sea change with a change in concepts. There's no doubt that infarct-related artery should be opened. That is anyway class 1A indication. There's no doubt in it. And stenting is a choice. For that, it is again class 1A indicated. What should be done for a non-infarct-related artery? It is going through changes in the guidelines. That's what I want you to highlight. They become a class 2A indications now. The latest guideline in 2021, I would throw light on it. Antiplatelets, I've already told you, ticagrelor or clopidogrel can be used. And then aspirin is used. Prasugrel, unless the patient is going for PCI, we tend to avoid with lytic therapy. So the unfractionated heparin is good enough in your practice. If you're following it, you can follow it. I advise you need not go to pivaridin and enoxaparin unless you have some particular contraindication. I'd touch briefly about a minute on this 2022 21 guidelines, it is not 12. So what they said is STEMI ischemic symptoms less than 12 hours. Anyway, PCI is a class 1A indication. The STEMI in cardiogenic shock or hemodynamic instability, PCI or CABG they mentioned. But I caution you not to send these patients for CABG unless your center is geared up for CABG. By the time they arrange for surgery, then the pretty amount of time is lost. Once the patient infarcts, there's no point sending for surgery. In that scenarios where you have triple vessel disease, we generally practice infarct-related artery opening. Once the patient stabilizes, then electively you can send the patient for surgery. That is general practice we follow. So guidelines say CABG within 6 hours. So if I have mechanical complications, obviously you will send this patient for surgery like VSD, MR. Then that is the only indication where I think in acute MIs, we send the patients for surgery. Then failed reperfusion or failed lymphatic therapy, again, even if the patient comes late, still you will send these patients for PCI. So that is about infarct-related artery. There's no confusion in it. But if this is the newer guidelines in the patients with revasculation of infarct artery, little late coming, all that is clear. But what is a little more confusing in asymptomatic patients, there are very small vessels involved. Now you need not send these patients to surgery or PCI if the patient is all right. This again shows the same thing what I've mentioned. Then a word about these non-infarct arteries in patients with STEMI. That's where we have some discussion. If a patient is hemodynamically stable with STEMI and multi-vessel disease, successful PCI and the staged PCI is what was recommended. If not in the same sitting before discharge or trial showed within 48 days, you can still do it, but we generally do it as a practice before discharge. That is PCA of other vessels. So then in the selected patients STEMI with complex disease, CABG could be also given a reasonable option, but provided your center is geared up for it. And then if a patient has arteries which are not very critically important, sometimes the trials also showed if it's not important, we can leave it. What is latest in 2021, which is different, I highlighted in red. Previously, we used to think in cardiogenic shock, you open up all the vessels possible because complete revasculation helps. But the latest guideline, it's set as contraindicated because it's supposed to increase renal failure rates and produce more trouble. So patient is in shock, only do the critical vessel, you need not open all the vessels. That's what is the latest guideline recommendation will show compared to what it was before. So that is the difference, and we only say culprit vessel. And there are various trials which are mentioned here, which came out with it. Aspiration thrombectomy, I've already covered, but we have to individualize according to the patient. CRISP-AMI trial, somebody asked about IABP, that's why I thought I would project this also. I included slides. We were part of this large trial, CRISP-AMI study. When they were not able to recruit, it came to India. We became the leading recruiters. Though IABP, it is difficult to, that was congratulated. It is difficult to produce mortality benefit, which is almost produce some advantages which did not become statistically significant, but it gives a lot of comfort to the operator in avoiding hypotensions happening during this procedure, though it didn't reduce the infarct size. That's about IABP in acute MI. I'd show you 1-2 case examples before I close. This sort of patients, 31-year-old males, unfortunately, we do see quite commonly, comes like in front of ER, he doesn't believe himself and gets into that sort of scenarios. After shock given, then you have ST elevations, and then ABP was inserted immediately. This sort of thing, why I wanted to project this is still we'd use IABP in such scenarios where patient is in shock, no blood pressure recorded immediately. It gives us some time to get some pressure back. And once IABP put, the teamwork also helps. My colleague puts an IABP, the other person starts off with doing this thing. And then you see this LAD has a total occlusion, so critical thrombotic occlusions with slow flow there. As you know, we repeatedly do thrombectomy. This is another why I wanted to project this. Yesterday, questions was about thrombectomy. Why are you using? See this sort of scenarios when you have chunks of calcium there. See that chunks of thrombus. You have to suck them out. And then once we did thrombectomy and we repeated it, and then sometimes we may not need a stent. This artery become totally all right. And we left it after this thrombectomy. And then once the flow comes back, as I said, pressures improve and the patients dramatically improve. So that sort of thing, but you need some critical care support in the post-op, immediate pulmonary edemas. And later on, ECGs improve dramatically. All these things were done before patient paid anything. So that's how once the patients improve, we feel happy about it. Day 3, patient became all right, came for follow-up, lost weight, and that's also thing is very important. One example of multivessel disease presenting stable hemodynamics, probably SC elevation about to come. Then you do infarct-related artery, the tight LAD disease. Then and the RC also has a critical disease, and LCX was borderline disease. And then immediate stenting was done. That is, if possible, direct stenting. Then patients improved. Then staged FFR to OM, whether to do it or not, we were having a doubt. So we did FFR pre-discharge, it came negative, and the left that thing, but RCA was looking so critical. We tackled that, and then we had to take all precautions to do a good job, post-dilatations to give good results, and then patient, now that's the final result, and the patient was discharged. Sometimes patients come in emergency scenarios like cardiogenic shock situations, especially post-bypass, and the graft get occluded in one of these patients. That's where we go out of the way to break the rules and do what is good for the patient. Then graft occlusions are producing trouble. Then we didn't have time to put filters and all that. So this is a native vessel. For sake of time, I'm skipping. So one of these graft vessels which had a tight stenosis, we opened up, and then probably Lima was all right as seen that this is our graft, venous graft coming into the RC had a tight stenosis. Then there is a tight narrowing. I don't know whether light you can appreciate. Then this is another graft which has a very tight occlusion. So when this sort of things coming, we might open up both, which are relatively straightforward. We did direct stenting of this graft. And also for the other graft, this is again, you have to individualize, see how the patient behaves, how the procedure is going, and take decisions. I wanted to stimulate some of your thought process, why you did two together. All that is again, but you need to be taking care of it, and patient is arrested. Initially, TPA support, IABP, all that will help in taking this. We did write a consensus document in STEMI, doing that in CSI, was part of it, and then very much thankful for all the support across the colleagues. I think time is up, it shows. That's how it's important to summarize, analyze these patients, and do what is best in the patient's interest. Thank you again. With this, I'll stop. I think we'll have Sir's talk on delayed presentation, thrombotic burden. Then we'll have Ramakrishna's talk of pharmacokinetic strategy. Then we'll have questions. Thank you. Your laptop. Get Sir's laptop. अच्छा दिया आपने But you want the laptop here? Or they want the slides from there? I want the laptop. Laptop here. Is it loud?
कोई भी लैपटॉप तो मैं अभी दे देता हूँ दोबारा पिन चाहिए I'll operate from here. You can. No, this, I'll need this also. I can operate from here. Okay.
Thank you, Dr. Sandeep, sir. Your colleagues and friends wrote entrances together. Now, sir became big and professor of cardiology. I don't know how many of you know, their center is a leading center for students or top ranks are picking up Safdarjung Hospital. First 24 ranks at cardiology seats are over there. So it's fortunate. Thank you for sparing your time and coming over to discuss with all of you. I requested him. Thank you, sir. Over to you for lecture.
Thank you, Dr. Srinivas, for this kind invitation. And my job over the next 15 minutes or so is to talk to you about a very common problem that we particularly face in our country, and that is the problem of delayed presentation, which is often accompanied by a high thrombus burden. So this is going to be the flow of my talk. We discuss what exactly is delayed presentation. We talk of how common it is and why is it important. Then we also talk of the familiar thing of thrombus burden. And then we finally see what are the drugs or devices and how do we go about managing it. This is a very famous diagram. This is a very famous graph that we all read in our textbooks. It is given in the Brown-Wald's Cardiology. This is something that came almost 20 years ago by Dr. Bernard Gersh. And this actually shows the time relation to, the, the time relation to therapy. And we all know that the golden hour is the first hour from the onset of symptoms, where if you move from D to C, say from D to C, there is a great reduction in mortality. And if you move from C to B, there is also a relative reduction. The time is up to 6 hours. And then there is a slower but definite reduction, and that is up to 12 hours. So anything which presents beyond 12 hours is actually called as late presentation. So this is currently the standard definition of late presentation. Anybody who comes beyond 12 hours. Most of the data has come from animal studies and also from clinical studies. It has been seen that in animal studies, most of the benefit was lost beyond 6 hours. But when we went on to do, and this data is again mainly from thrombolytic therapy, it should be even better with BCI. But what we learned was that even up to 12 hours, there is a significant benefit. And therefore, why this happened? Because, in animal experiments, we just ligate the artery and look at how the infarction takes place. Whereas you have collaterals, you have, many a times the occlusion in the ST elevation related vessel is a dynamic or intermittent occlusion. So we get benefits up to 12 hours. Now, further down, how common is late presentation? In Western literature, the figure mentioned is between 10 to 20%, mostly between 15 to 20%. And at the bottom, I've mentioned the CREATE registry, which is the Indian registry of a couple of thousand of patients. And as we can see, the yellow figure in that, the yellow box, it says almost 1/3 of the patients in India with ST elevation MI. The figure of 42% is with non-ST elevation MI. But with ST elevation MI, almost 1/3 of our patients actually present beyond 12 hours. So with us, it is a very common problem. It has also been seen what are generally the clinical features of these patients. That they are older, a lot of them are women, diabetic patients, particularly patients whose initial presentation is a atypical chest pain. And on the other hand, if a patient is a known case of coronary artery disease, has had a prior MI or PCI, then they tend to wait lesser. The single most important cause for delay is actually on part of the patient. We all know our patients, it's a natural human tendency also, which is exaggerated in our part of the world. People have a self-denial, mujhe to heart attack nahi ho sakta, and things like that. During the COVID, it was also seen that the delay was attributable to one other factor, that most people avoided going to the health services for problems other than COVID. They delayed the, coming to the hospital. Switching gears, how about thrombus? See, we all know that whenever the plaque ruptures or erodes, there is an exposure of the subendothelial thrombogenic surface to the platelets. The platelets adhere to themselves, they aggregate, and a white thrombus is formed. After that, there is a concomitant release of tissue factor at the arterial injury site, and the external or the extrinsic coagulation cascade is activated. This leads to the red blood cells getting aggregated, and we get what is known as the red thrombus. So if my patient has had shorter episodes of occlusion of the artery, the predominant thing that we find, particularly in unstable angina and non-ST elevation MI, is a white thrombus. When the artery gets occluded and it has been occluded for some time, the extrinsic coagulation cascade has been activated, we find the the red thrombus. And we also know a lot of other factors which are vasoconstrictive and aggregative factors. They accumulate over a period of time. This clot consolidates over a period of time, and then it becomes very difficult to disrupt. And that is the problem with delayed presentation patients. What is the frequency of large thrombus in ST elevation MI? In the Western literature, it is again 15 to 20% of the patients who present late have a large thrombus burden. And in the Indian scenario, this is a paper from Dr. Ranjit Nath, published in 2020 in Indian Heart Journal. About 16 to 18% of our patients also have a very large thrombus. Is it possible to predict that which are the patients that are going to get up or get a large thrombus burden? If the patients have a high syntax score, that has been correlated. If you have a higher troponin level and CRP levels at the baseline, these are associated with higher thrombus burden. An interesting thing that has been found, and this paper is a couple of months old in Medicine Journal, is this high CRP to albumin ratio. Any one of you who's going to take up thesis, this can be a very good thesis topic. CRP to albumin ratio, as a predictor of thrombus burden, it has been seen that it is a predictor of high thrombus burden. Besides that, if your WBCs are very high and you're presenting blood glucose is high, they are again predictors that you may have a high thrombus burden. Angiographically, when we do angiography, what we find is that what are going to be the predictor, proofs that the thrombus burden is going to be high. If there is a cutoff occlusion, if there is a thrombus which is occluding prior to the actual obstruction, if you find that the lumen of the infarct-related artery is more than 4 millimeters and incomplete obstruction, but the thrombus that you see is far greater than the greatest luminal diameter, or if you have floating thrombi, and like the proximal obstruction, if you have persistence of dye beyond the obstruction, that also is a proof that you are likely to deal with a large thrombus burden. How do you classify the grading of thrombus? This is the TIMI grading that we all know. It is given in the textbooks. And the important thing is that grade 4 and grade 5, when the thrombus is more than 2 times the diameter of the vessel, or there is a complete thrombotic occlusion, those are known as high-grade thrombi. So the other way in which people have used to classify the thrombus is low-grade thrombus, which is grade 1 to 3, and high-grade thrombus, which is grades 4 and 5. There is also a new score which has been published in 2022 from a Turkish group, and they give it a score which is called the MAF score. It's a very elaborate paper. I can't give you the exact score, but Suffice to say that there are scores that exist which can tell you that the thrombus burden is high. So the next question, comes whether we should intervene at all in late presenters. And there is a British Cardiovascular Society editorial by Dr. Evelyn Brown. She shows that if you have any problems beyond 12 hours, particularly heart failure or left ventricular dysfunction, then it improves the survival if you do an angioplasty. Similarly, it has been seen that even in those patients who do not have heart failure or any major complications, stable patients between 12 to 48 hours, and this was an important trial called the BRAVE-2 trial, based on which the European Society of Cardiology currently says that it is a class 2A, not class 1, but a class 2A indication to be able to do angioplasty in patients of ST elevation MI between 12 to 48 hours. So what I practice in my center and what I teach my residents is that if your patient comes within 48 hours of myocardial infarction, you can go ahead and do angioplasty in those patients. There are other registries and large observational studies, which again have shown that there is a benefit, not in terms of mortality. There are some trials which show mortality benefit also, but the major advantage is in terms of myocardial salvage. It has been seen that you can salvage up to 5% of myocardium. That's a sizable percentage of heart that you can salvage if you do angioplasty in these patients. There are other trials again which show that the salvage is better, with some showing plus minus benefit in terms of mortality. There is one randomized controlled trial, which not exactly randomized controlled trial, but a very selected trial actually, which showed that there is indeed a mortality reduction. If you take out the patients in the first 48 hours and you analyze them, this is from the US, they actually showed that almost 70% of them underwent only PCI and no thrombolysis. And there was a mortality reduction at 1 month, at 6 months, and even at 5 years, there is still a mortality reduction. What are the treatment options that we have? We have options of drugs that have been highlighted here. So please remember, whenever your patient presents to you with acute coronary syndrome, the first thing you do is give a 325 milligrams of Disprin, not Ecosprin. Please remember, not coated aspirin, it is the soluble aspirin, and we all know that the best aspirin in our country available is the good old Disprin that we should give, preferably dissolved in half a glass of water. And along with that, we need to give 180 milligrams of crushed ticagrelor, because it has been seen that if you crush it and give it, then the onset of action is much faster and the blood levels achieved are much faster. There are specific scenarios wherein GP2B3 inhibitors have been used. Anticoagulants, plus minus data, doesn't say much whether you should use unfractionated heparin, or you should use enoxaparin, or you should use bivalirudin, which is available in India but not so very well used. It is more used in the West. Vasodilators do help: nitroprusside, adenosine, calcium channel blockers given intracoronary like deltazim. And there is some role of intracoronary thrombolysis when you have nothing working. I tell my residents that the treatment of large thrombus is actually intracoronary thrombolysis and not anything else. We also have, the aspiration devices that Dr. Srinivas touched upon. In this particular scenario, where we have backs to our wall, backs to the wall, aspiration is the preferred strategy. It can be manual, it can be mechanical, such as angiojet or exciser. Laser is now available, and the role of embolic protection devices is not that great. So this is This is the flow chart. If you get a thrombus grade which is 3 or 5 and you have achieved an antegrade flow, you don't need to do anything else. But if there is no antegrade flow, you go ahead with thrombus aspiration, and then you can do a direct stenting, or you can also have a deferred stenting strategy. Between mechanical and manual aspiration and therapies, this is a meta-analysis almost 10 years old, but this clearly showed that in terms of major adverse cardiac events, reinfarction, aspiration thrombectomy, the good old suction that we apply to our aspiration devices, that is good, whereas mechanical thrombectomies are associated with higher problems. This is an elegant paper from Korea, from the KAMER registry, Korean Acute MI registry, which says that the effect of thrombus aspiration may be having a U-fold relation. There is one randomized control trial, a small trial of about 150 patients, which actually studied the endpoint of microvascular obstruction using CMR, and it was seen that there was no great benefit. So plus minus benefit, it has to be individualized. Do we use intracoronary, GP2B3A inhibitors? Traditionally, abciximab has the best lytic property when given intracoronary. However, it is a costly drug, and it also has antibody formation, so it cannot be reused in the same hospital setting. Most popularly used are either eptifibatide or tirofiban, and they actually, if we look at the first 3 columns, they improve the flow characteristics. They improve the incidence of TIMI3 flow, the frame counts, and also the blush grade. So those are the benefits, softer benefits. Then comes this problem of deferred strategy. Deferred strategy has to be used in only, it is usable only in 1 to 2% of patients of ST elevation MI, but there is a prerequisite. Number 1, the thrombus burden has to be high. It has to be a grade 4 thrombus. You can't do it in grade 5. And it is also not useful in grade 1 to 3. If you have a grade 4 thrombus, that means the thrombus burden is more than 2 times the diameter of the coronary artery, then and you have a TIMI3 flow. You don't do it in occluded vessel. Please remember, if you have a TIMI1 flow or a TIMI2 flow, you don't adopt the defer strategy. So high thrombus burden with a TIMI3 flow, that is the only place where defer strategy works. And this particular meta-analysis, which came last year, again showed that the deferred strategy can be beneficial in very selected cases. So I'll show you in the end a case that we did recently. A 42 years old male presented to us at about 13 to 14 hours with acute severe chest pain. His ECG was suggestive of anterior wall MI, and he was taken up for primary PCI. And as we see here, this is the right coronary artery, which is normal. This is the LAD, which had a very proximal obstruction, total cutoff. Then we wired it, and you can see the balloon coming up, because if you have a grade 5 thrombus, the first thing is to dilate it with a small balloon, a 1.5 or a 2 millimeter balloon, and then reassess and tell what is the severity of the thrombus. So here we can see there is a trickle of flow, but there is a heavy thrombus burden that is still pre-existing. So what we did, we dilated it with a longer balloon and a 2.5 millimeters balloon. Some flow comes, and then we go ahead. If you can see, appreciate the small dot moving here, that is our thrombus aspiration catheter. We do this and we get a better flow. We are able to implant a stent and we get a TIMI3 flow. So we were lucky that we could get a good result in this patient, but in many patients, we are not that lucky. So finally, what are the European Society of Cardiology ST elevation guidelines? in terms of delayed presentation. If your patient is presenting within 12 hours, no matter what the situation, the default strategy is primary PCI. For more than 12 hours with ongoing symptoms, if your patient has ongoing chest pain, if your patient has heart failure, if your patient has any arrhythmias, then again, primary PCI is recommended. If the patient has presented to you within 12 to 48 hours, so you can still go ahead and do a primary PCI even without complications. It is a class 2A indication. It is guideline mediated. In US, the guideline is up to 24 hours, but we should be able to accept what is more acceptable to us, and that is the European guidelines, which is up to 48 hours. If your patient is more than 48 hours, do not do an angioplasty in these patients. Your patients die. We all learn a lot from each other by talking to each other. And over again, a lot of my friends, a lot of my cardiology colleagues have told and informed that when they did interventions on day 3, 5, 6, they lose the patients. And again, what we learn from our peers, a lot of my peers have told me that it is the right coronary which bursts open. It causes more complications. I thank you for your kind attention.
Next, I would invite Dr. Ramakrishna J to take us through STEMI post-lysis pharmacokinetic strategy. So Dr. Ramakrishna is a senior consultant cardiologist at Apollo Health City, Jubilee Hills, and he has expertise in various clinical and interventional cardiology techniques. Yeah.
Very good afternoon, everyone. And thank you for giving me this opportunity. I'm Dr. Ramakrishna. I thought of discussing guidelines, but already guidelines were extensively covered by Dr. Srinivas Kumar sir and Sandeep sir. And as a brief introduction, the coronary artery disease is the most common cause of death in India. So it's not coming. Slides. Okay. So this is the most common cause of death in India and even in the Western world. And one of the most dreaded complication of this spectrum of CAD is STEMI. So we need to have some sort of therapy, that is reperfusion therapy. It's a time-dependent key management strategy in many acute MI patients. There are many guidelines, but there is a lot of gap between the guidelines and what we practice daily because of various reasons. So this is the data from our National Interventional Council. We published in 2020, 2018-19 data. This is the retrospective data. Out of all MIs, there is only 18% of the patients underwent primary PCI. So with you all becoming comfortable doing in primary PCIs, these numbers will go further up. And many patients are undergoing post-MI PTCAs. Almost 440,000 PTCAs were done in 1 year in our country from the reported centers. But still there are many centers which are not reporting the data. And we need to improve on this primary PCI. But many patients underwent rescue PCI and almost 3 to 4% of the patients had cardiogenic shock. So this is a coronary artery disease, initial plaque formation followed by progressive narrowing leading to chronic stable angina, and then one fine day they may develop ACS. So you should be familiar with this terminology, as already it's mentioned. There is a rescue PCI. when we define it as a rescue PCI, it's a emergency PCI performed as soon as possible in cases of failed fibrinolytic therapy. Already patient received fibrinolytic therapy in the form of thrombolysis with either it may be tenecteplase or streptokinase or alteplase, and routine early PCI strategy after fibrinolysis. So coronary angiogram is performed 2 to 24 hours after successful fibrinolysis. This comes as a routine. What is pharmacoinvasive? Combining both these two, it's a pharmacoinvasive. This means you already did some pharmacotherapy followed by invasive therapy. So this already covered in the previous talks. We need to have some sort of reperfusion therapy. We need to open the occluded vessel. So we have two strategies. That is, one is fibrinolysis and other is the primary percutaneous intervention. And pharmacoinvasive strategy is combination of both these two methods. So this is from ESC 2023 guidelines. So as this is already mentioned, so if the patient present directly to a PCI capable hospital, the primary PCI is the gold standard and it is a class 1 recommendation. If the patient is presented to a non-PCI capable hospital, and if the patient can be transferred to a PCI capable hospital within 120 minutes, that is within 2 hours, still the primary PCI is the preferred option. And if it is not, that is possible. Suppose if the patient is presented in a rural hospital or in a district or some of the districts or some of the states with poor medical infrastructure, you decide as early as possible for fibrinolysis. If you decided for fibrinolysis, you have to administer the fibrinolysis within 10 minutes. Like try to achieve this time period of less than 10 minutes of giving a fibrinolytic therapy to these eligible patients. So with classical STEMI. So there are various delays in the system that increases the time duration of ischemia and thereby leading to increased mortality. We need to cut down on these, whether it may be patient related or it may be system related delays. So time is muscle or time is heart. So as you delay more and more, for each 30-minute delay in STEMI patients, there is an increase in 7.4% increase in 1-year mortality. And mortality benefit with primary PCI is lost if PCI related delays exceeds more than 1 hour. If you do more than 1 hour delay, even after presenting to a PCI capable hospital, the whatever benefit you are going to give to the patient is lost within the 1 hour period. So in our country with large difference between urban and rural areas, the fibrinolytic therapy is the best suitable for many patients. That is studied in the Tamil Nadu STEMI program or STEMI India program that has shown significant reduction in mortality in the patients who presented with STEMI in the peripheral hospitals. So this already covered by Dr. Srinivas Kumar. Still PCI is the primary option. So this I'm skipping this because it's already covered. So these are the after fibrinolysis, what you have to do. Suppose if you are in a peripheral hospital, what you have to do, immediate transfer to a PCI capable hospital is the class 1 recommendation. So emergency angiogram and the PCI of infarct related artery is class 1 and angiography of infarct related artery if indicated in between 2 to 24 hours. These are all class 1 recommendation as per guidelines. We have to follow that. So this already mentioned in the previous slides. So what are the types of thrombolytic therapies? So we have the fibrin specific and non-fibrin specific. So non-fibrin specific comes as urokinase, streptokinase, which are the older generation thrombolytic agents. And with the, except for cost, the tenecteplase, retiplase, and alteplase are easy to administer with relatively less side effect profile when compared to the streptokinase. So less chance of hypotension and all. So the fibrin specific agents are preferred over the previous generation non-specific fibrin, non-fibrin specific agents. So I will show you some of the cases where it's a great savior in many patients. So this is a 45-year-old male farmer in one of the rural areas and was no diabetes, no hypertension. He had only smoking. He presented to a hospital with chest pain of 2 hours duration. This was his first ECG. So what you are seeing, there is hyperacute T waves with reciprocal ST depressions in the inferior leads. So this is acute MI. So he received thrombolysis with retiplase, so 2 doses. So after receiving retiplase, there is some reduction on the ST elevation. And but still some amount of residual reperfusion need to be happened. So after 6 hours of thrombolysis, you can see this ST elevations has come down, but the patient had developed QAS. So, but he became symptom free. He came to us in the next day. He is symptom free, and we did angiogram. So you can see proximal LAD significant stenosis with reduced flow in the distal LAD. So there is a TIMI2 flow. So we stented this patient, and he is doing good since almost 2 years. So this is a case of successful pharmacoinvasive therapy. So this is another case of 40-year-old male, non-diabetic, non-hypertensive, non-smoker, only family stuff, coronary artery disease, and he presented to a hospital with chest pain radiating neck since 5 hours. So this was his first ECG. You can see huge ST elevations in the anterior leads in the V1 to V3. So he underwent thrombolysis, and after 90 minutes of thrombolysis, his ECG, there is some resolution of ST segment elevation, but while he reached to our center, he still had pain. So the symptoms, correlation of symptoms is very, very important. So we did immediate angiogram. So you can see the LAD is completely occluded even after giving thrombolysis and resolution of the ST segments. So we did stenting of the infarct related artery, that is LAD. So after that he was stable, but he developed LV dysfunction. So I will show you other case scenario. He is a 28-year-old male smoker and chest pain of 10 hours duration with ongoing pain while admission to hospital. He tried all his homemade remedies like consuming antacids, and everything. And because still pain is not coming down, he came to hospital after 10 hours of pain onset. You can see this. So what is the problem here? In this, you are seeing a huge thrombus burden starting from the ostium of the left LAD. So you are having the left dominant system and along with a big ramus. So what you will do? How many of you do thrombosuction in this? How many of you go ahead and put a stent? 31-year-old left dominant system starting from acute coronary syndrome, 10 hours duration. So what we did in this? So this is other epicardial view. So you can see large thrombus burden even beginning from the LAD ostium. You can see only TIMI1 flow in the LAD in the distal portion of the mid to distal portion. So RCA is normal. So what we did, because this patient is young, so it's still within the window period of 12 hours, we did thrombolysis. This is reverse of pharmacoinvasive, that is invasive pharmaco method. So we did thrombolysis after shifting out of the cath lab. So after 24 hours after thrombolysis, we put him on heparin infusion. After 24 hours, you can see there is almost near complete resolution of the thrombus in the LAD. So even in this is before and this is after thrombolysis. So you can see the complete resolution of the thrombus in LAD. This patient is kept on medical management without putting any stent, but still there is some amount of residual thrombus at the apex. This is other cranial view. So there is some amount of distal thrombus migration. So this another case scenario of 33-year-old male, same non-diabetic, non-hypertensive, non-smoker, chest pain of 10 hours duration and increase since last 3 hours. So you can see this patient. So still this non-dominant circulation with a ramus and L6, and there is some amount of moving thrombus. There is dancing thrombus in the distal left main with complete occlusion of the LAD. So, sir, duration is around 12 hours. So we were feared about like some late complications of thrombolysis, like myocardial rupture. So we went ahead and putting a wire in the ramus and one wire in the LAD. How many of you do thrombosuction in this case? There is some amount of moving thrombus in the left main, thrombosuction. So we went ahead and so the thrombus is already there in the distal left main. So we balloon dilated it and I placed a protective wire in the circumflex. That has to be done because this thrombus has to, definitely it will migrate into the other vessels. So patient already had 10 hours duration of LED occlusion. And if you occlude any other branch, even if it is a minor OM, that will be catastrophic on table. So you have to be very, very careful in these patients. So I placed a stent. So after balloon dilatation, there is some amount of flow. So still there is large amount of thrombus moving in the distal left main. So I placed a stent covering the ostium of the LED and with minimal protrusion to left main. So after stent, what will happen? This, we gave some intracoronary terifibon, everything we did, but still this thrombus is dancing in the left main. So how many of you leave at this stage? So there is still some amount of thrombus, and but flow is achieved in the LED. And after stenting, there is some amount of migration of thrombus into L6 and into mouth of the ramus. How many of you leave? The patient is asymptomatic. And if you are the lone cardiologist at that center, or how many of you put a stent in circumflex? It's a TIMI 3 flow in the circumflex and ramus. So what I did is, I did some amount of intracoronary thrombolysis. I gave 10 mg of tenecteplase on table because I already gave terifibon. I have taken a chance because it increases the bleeding risk. But is a young, I gave terifibon, I gave adequate dose of heparin, but still I gave 10 mg of intracoronary thrombolysis. So I waited for 10 minutes on table. So this is after 10 minutes. There is some amount of resolution of the thrombus in the ramus, but some thrombus in the. This is after 20 minutes. After 20 minutes, you see TIMI 3 flow in LED, L6, and but still there is some amount of thrombus in the diagonal, large diagonal ostium. But there is complete resolution of the thrombus in the circumflex. So this is an example of intracoronary thrombolysis. So this is a 60-year-old gentleman with chest pain of and breathlessness of 8 hours duration, and he was treated with. He presented to a hospital with borderline blood pressure of 90 millimeters of mercury, and he was treated with streptokinase at one of the peripheral centers and referred here in view of persistent shock. When we did our angiogram first, this was his first picture, that is complete occlusion of the left main. How many of you sent for surgery at this stage? Patient in shock, left main occlusion. Nobody? Okay. Then because he is in shock, we tried to open the vessel. We placed a wire in the circumflex and one wire in the LED. So even after balloon dilatation, multiple balloon dilatations, even after thrombolysis and heparin, but still there is no amount of, there is no improvement in symptoms after crossing wire and balloon. So because the BP is only 60 or 70. So this, we placed a stent from left main to LED covering the circumflex ostium. After placing stent, there is some amount of flow, but the flow is not that great. So this patient was in persistent cardiogenic shock. We placed IABP after the procedure, but all the stories will not be successful at the end. So this patient died on the day 3 because of renal failure and persistent shock and sepsis. So coming to end, the timely PCI is not feasible in our country with vast differences in the infrastructure and trained doctors. So pre-hospital thrombolysis or pharmacoinvasive therapy is an important step to reduce the time delays, and early thrombolysis in India would be a suitable option. Pharmacoinvasive approach is an important option for India, and it can cater large amount of population with improved mortality and morbidity in many patients.
Thank you, Ramakrishna. I think we can have some discussion if anybody has any doubts in any presentations, anything related to MI, STEMI. Sir is also here.
See, the most common that we have used is tenecteplase, generally 10 milligrams given intracoronary. However, in the same breath, I can tell you people have used everything, including streptokinase. We used to give 250,000 units of streptokinase as a short infusion, which was preceded by 1 lakh units intracoronary. That also I have given and presented at TCT Asia Pacific. I used to think that streptokinase cannot be given intracoronary, but then when I reviewed literature, there are series from Turkey wherein people have actually used in 50 patients, 80 patients. So it is safe to use that. The only thing is that whenever you have done that, you need to have very effective, antiplatelet therapy. You cannot meddle with the antiplatelet therapy if you have given the thrombolytic. Please remember that. And the other thing is, we all forget what we have read. In the thrombolytic therapy, first time in the world when it was given intracoronary. The thrombolytic therapy was started in Russia, and it was given intracoronary to begin with. It was only when it was found that we had an easier way of giving it intravenous in the GC trial that we started using intravenous.
Yes, thank you, sir.
I think if
And
tenecteplase.
sir, actually, remaining dose of the intracoronary thrombolysis has to be given follow-up as an IV, sir?
No.
That has to be done, or?
No, it's not recommended. But once reconstituted, most of these agents can be used within 24 hours. So don't use it on that patient, use it on somebody else.
Right, thank you, sir.
Sir, the third case where the LED was having a grade 4 thrombus. You did the reversal of pharmacoinvasive therapy. Could you have done intracoronary thrombolysis in that case?
Yes, intracoronary thrombolysis was one option, but it's like off-label indication. There is no guideline recommendation. Suppose tomorrow something happens to a young patient. So that's why we kept the sheath and we shifted him out. So we did thrombolysis and we did check angiogram after 24 hours.
One thing we need to understand is if the patient's hemodynamics are okay, blood pressure is all right. Patient in shock is a different scenario. The blood pressure is all right. I feel most of these agents have systemic effects too. Whether you give lysis in the coronary or the IV, still it could be okay. That's how the comparison studies between IV and intracoronary did not show difference. But it doesn't apply to the same to patients in shock type of situations where you need to directly deliver the drug there. And sometimes also slow flow type of scenarios where the drug may not reach there, that's a different story. But by and large, if patients' hemodynamics are okay here, the flow is adequate, then giving it directly there or giving it is no problem. Especially now in the era of radial procedures, we are not too worried about bleedings also. You can do it, and suppose if it doesn't go, we can always practice further procedures. That's the advantage of having switched to radials.
For the same case, sir, why didn't you do thrombus aspiration? Because it was a large chunk of thrombus, is it so?
Yeah, whatever you do, it will come to other vessels. Even in the third case, it's starting from LED ostium. And in the fourth case, there is some amount of thrombus moving inside the LMCA. So if you do some meddling, it will come and go into circumflex and patient will crash on table. Many of the times it will happen. So you have to be very, very careful with the non-infarct related artery while doing PCI for primary PCI. Even minimal thrombus, minimal air to a non-infarct related artery, it will create a lot of troubles.
Actually, these are some scenarios where I think we could do a randomized comparison between tenecteplase and a primary PCI field, but it's difficult. I tried, but many of them did not agree to participate because primary PCI is already proven beyond therapy. But young patients around 30, 40 years of age, presenting very early within 2 hours of duration, and many of the times we see tenecteplase also works very well. Because now this is better opening rates compared to streptokinase, which had 50% opening rates. This is 80%. Many of the times it works well. And you take the patients up later for angiogram, already the artery is open. if you're taken for primary PCI, you would ended up with stent. That's what bothers sometimes. So you have to identify a particular subset of patients where you could avoid usage of stents, especially young patients. If you left with the same patient, you are taken immediately, as you said, thrombectomy, then you would be forced to put a stent, would have ended up with stent. That's what. But finally, the greatness of a primary PCI is you document on table that perfusion is well established, which lacks with lytic therapy. But again, later on, when you're taking up for angio, we'll document it. That's how I think we have to study. I think with no further questions, we're slightly delayed already. Sandeep sir, you want to say anything before you close? Okay. Thank you. I think many of you now understand that tenecteplase is a more useful and easily usable and very user-friendly molecule. I keep telling whoever is comfortable giving IV ranitide injection, you can give tenecteplase, not much of problems or side effects. Patients, even if unstable patients, we have noticed that patients are given in periphery. The only thing is you have to identify right patient and give that molecule. Immediate caution is again, give immediately it should be short acting, so it should be immediately followed by giving heparin, unlike streptokinase where you used to avoid giving heparin for 6 hours. So otherwise, reocclusion rates are quite common with the tenecteplase because short acting. But if patient is going for procedure as a pharmacokinetic strategy, there's no worry of bleeding because fibrin specific and nowadays the radial, that worry is not there. But even otherwise, it is less likely to produce trouble. That's the advantage of, I think, usage of latest same pharmacoinvasive strategy what Dr. Ramakrishna proposed may not be totally correct with streptokinase. Those Indian studies showed that streptokinase is also good enough, but it could be having some troubles. But tenecteplase that way is quite safe. That's how many of the international studies done with tenecteplase and alteplase showed it's good enough, and more so for Indian scenario. All of us, though you are interested in primary PCI, I think this also you should keep in mind because the place of presentation where the patient is contacting you, all that matters. So if it's taking more than 2 hours, then probably now you suggest to them to give lytic therapy there itself and then shift the patient. So it is win-win for everybody. Peripheral cardiologists, I keep telling, you can also give the drug, you have the satisfaction of treating patient there and immediately shifted here. Patient response, it's fine. Otherwise, we can always tackle up the patient. So patient is not at loss. Treating cardiologist is also fine and the invasive center is also okay. So finally, this win-win situation for everybody, which should be followed and practiced. And the only thing is we need to identify right patient. Obviously, as a cardiologist, you have no problem. But we did advise that technology, these WhatsApps and all that help us in identifying right patient and giving this molecule to right ST elevation MI patients. Thank you, I think. Now we'll go on to the last interesting session before we all break.
Yeah.
On the newer interventions. I keep telling this has been my passion about stroke interventions. If you see in practice, normally acute MIs, sorry, you want, huh?
Need to have felicitation.
Okay.
Yeah.
Sir is leaving, huh? Huh? Okay.
Dr. Sandeep Bansal has left, I guess. So I would request Mr. Sandeep Sharma to please felicitate Dr. Ramakrishna. We'll move on to the next. So then we move on to the next session, which is newer innovations, which would be taken by Dr. Rajesh Reddy. Dr. Rajesh Reddy is the senior consultant, brain, spine, and endovascular neurosurgeon at Nalaganda. He is the life member of the Neurological Society of India. So I would request him to take the session.
Good afternoon, everyone. First of all, I thank Dr. Srinivas Kumar sir and team for making me a part of the scientific program. Sir has always been enthusiastic about collaborating with the concerned departments about extending therapies for the welfare of patients. So it's a good initiative and I'm happy to be a part of this program. How many of you encounter either patients or family friends asking you about opinions on stroke, thinking it is heart attack or heart stroke? Have you encountered patients or family members? Because people keep asking me about, am I heart attack? So it's always nice to know about heart stroke as well. So that's so I'll keep the talk very basic. So I'll start off with case scenarios. 66-year-old diabetic hypertensive with sudden onset weakness, right upper and lower limb, and inability to speak, with gaze preference, and the time of onset of symptoms is 2 hours. A second scenario, same age group, similar comorbidities, same clinical presentation, but 4.5 hours since the time of onset of symptoms. Another scenario, similar age group, same comorbidities, same clinical presentation, but the time of onset of stroke is not known. The patient was seen last normal before going to bed at 10 p.m. and he woke up. I mean, he was not woken up. He was found at 5:30 a.m. in a drowsy state, inability to speak, weakness of the right half of the body. Another scenario, young patient, no medical comorbidities, similar clinical presentation, but 2 hours since the onset of symptoms, but he had a surgery 14 days back for an anterior cruciate ligament tear. A last scenario, a 70-year-old female, similar comorbidities, same clinical presentation. Again, the time frame is 7 hours from the onset of symptoms, but she had a background history of atrial fibrillation for which she is on and novel anticoagulants. So these are different clinical presentations. So, so my lecture is outlined this way. What most of us or some of us are familiar with in terms of stroke. Secondly, how things have evolved. The guidelines have evolved, the concept have evolved in the last few decade or so. And finally, what is the pathway for an acute ischemic stroke? So most of us right from our undergraduate days are familiar with the symptoms of stroke, both the anterior circulation and posterior circulation stroke. 85% of strokes are ischemic strokes, and if identified appropriately, can be treated appropriately and neurological deficits can be reversed. Like time is a brain concept is a very familiar concept because with the passage of time, it is known that several neurons die, and when neurons die, they are usually irreversible death. So time is very crucial for intervention. The treatment options would be either broadly medical or endovascular. Medical, again, depends on the time of presentation, whether it is just antiplatelet medication or is a role for thrombolysis or not. Sometimes thrombolysis is bridged with endovascular therapy, which has been found to be effective for endovascular stroke treatment. It is very well known since 2015 with the trials that endovascular therapy definitely has a role in the treatment of acute ischemic stroke, but the case selection is very important. It has been found that the number needed to treat to functionally to prevent one functionally dependent outcome is 5.4, which is much better than the percutaneous coronary interventions, and it doubles the rate of good neurological outcomes, and it reduces the mortality by almost half. So the interventions are talked in the next lecture. So thrombolysis for acute stroke from 1990s has been going on, and with a lot of data available, it needed refinement of data to categorize patients into who is apt and how to extend time frames. So with all the available data, it was found that some patients do well with thrombolysis, some patients may not do well with thrombolysis. Similarly, with interventions, some people do well, whereas others don't do well. So studying all the data, it was found that the three important factors which determine the outcomes are classified as 3 C's. The first C is the core. Core means the ischemic core or the dead tissue, and how much of surrounding tissue can be salvaged, which is the ischemic penumbra. Second thing is the collaterals. Brain has got amazing amount of collaterals, which vary from person to person. In fact, if stroke was there and you don't treat it, 20% of them recover spontaneously because of the natural mechanisms in the body, which are fibrin lytic mechanisms, as well as the collaterals which sustain. And sometimes you do an angiogram for chronic occlusions, you see that the whole brain is being supplied by a single vessel, and it is sustaining based on that single vessel. So it is not just the timing of stroke, but how slowly or it has evolved over a period of time, which determines how the brain has got capacity to tolerate that ischemic insult. And third thing is the clot burden. So let's understand this ischemic core concept. Suppose this is a internal cerebral artery, the middle cerebral artery, and the anterior cerebral artery. There's a block. This black color thing is the block over here. So this area is at risk, a maximum risk. And the area which is slightly pinkish over here, the tissue over here is determined by the collaterals, which are supplied either from the anterior circulation or posterior circulation. And we know that The normal blood flow to the brain is around 50 ml per hour. And as the blood flow decreases, there is an electrophysiological failure. And finally, there is a metabolic failure at the cellular level. And only then it becomes an infarcted tissue. So the center core cannot be reversed, whereas the surrounding penumbra can be salvaged. But the question is, how do we identify this surrounding penumbra? We have to image the brain. And all of us know that there are two imaging modalities for the brain. One is the MR, the other one is the CT scan. CT scan, if there is a black tissue on CT scan, it is well understood that that tissue cannot be salvaged. So it is dead tissue and that cannot be reversed. If you see the MRI, if you look at any MRI brain, there are so many sequences. Now, each sequence is a particular information to give us. And the third thing is the angiogram. We cannot do angiogram in every facility. So, but this is to explain the ischemic core concept. If you see here, in both the cases, the middle cerebral artery is occluded over here. In the first scenario, the patient A has got a good collateral flow with the anterior cerebral artery supplying up till this territory. Whereas the second patient, the anterior cerebral artery is not able to supply this territory and it has got a poor collaterals. So definitely we know that patient A has got a better chance of improvement following revascularization therapy when compared to patient B. But like I said, we cannot treat every patient with do an angiogram for every patient. So these trials, 2015, was a year when neurointervention for ischemic stroke became very popular. But thereafterwards, the following trials, 2017, the DAWN trial and the DIFFUSE trial, made use of these techniques to identify which patient is at risk and which can be salvaged brain tissue. If you see the investigations available, the metabolic investigation in terms of measuring the cerebral blood flow with a PET scan is the ideal test to identify which tissue can be salvaged. But in an emergency situation, we cannot do PET scans for every patient. So what are the other options available? We have a CT scan and an MRI. So when we do a CT scan, it is always recommended for a stroke patient that it is followed by a CT angio and a CT perfusion study, because that will tell us how much of area is already infarcted and how much of area can be salvaged. I won't go into the finer details, but that is based on the cerebral blood flow, the cerebral blood volume, and the mean time to transit that particular area. These are the parameters used in the CT perfusion. Whereas an MRI, in the MRI, acute stroke is identified on the diffusion MRI scan. A diffusion MRI scan shows that, let's say this is the diffusion MRI. Diffusion MRI shows that there is a white spot. That means that is the area of stroke. Now, there is another sequence called the flare sequence. If you see a bright spot on the diffusion MRI, and if you don't see that bright spot in the flare scan, that means it is a salvageable tissue. On the other hand, if you see both the diffusion and flare showing the same amount of intensity changes, the same territory, that means it is an irreversible damage which has happened. So this is one way of identifying whether the tissue can be salvaged or not, apart from the CT perfusion parameters. The second thing is the same MRI can be used in the form of a perfusion MRI, and the perfusion study will give us which territory is at risk and which territory is not at risk. Each of these two investigations, a CT-based protocol or an MR-based protocol, have their own advantages and disadvantages, but we'll not go into the finer aspects of that. Institute has got their own pathway depending upon the available resources. Both are equally good options. Whereas a posterior circulation stroke is better made out on the MRI, unlike a anterior circulation stroke, and that is where clinical examination comes into picture when you order an investigation. So this is a CT perfusion image, which will give so much of information about which area is blocked and what is the cerebral blood flow to that area, what is the volume in that territory, and what is the time taken to travel to that area of block, and so on. Because in the middle of the night, these things are difficult to interpret because you need a radiologist who can sit and analyze all these parameters. Similarly, a technician should be able to follow the correct protocol. Now we have the artificial intelligence. There are softwares available where the technician just needs to follow the method of doing an angiogram right from the aortic arch to the neck and intracranial circulation. And thereafter, within 10 minutes, the message will come to the operator or the radiologist about how much of brain tissue can be salvaged. So these are the artificial intelligence softwares. Most commonly available is used as the rapid software. So that a patient comes to the ER, the imaging is done in 10 minutes, you get a reply after the imaging as to how much of tissue can be salvaged and how much of tissue is already dead, based on which you can proceed with either the thrombolysis or the endovascular treatment. Now, thrombolysis, as we know in stroke, is extended from 3 hours to 4.5 hours. And thereafterwards, it was even studied up to 9 hours because based on these perfusion images, if there was found to be a tissue which can be salvaged, why do only thrombectomy? Why not we do thrombolysis in these patients beyond the 4.5 hour window period. So this trial studied the thrombolysis up to 9 hours. Although there was found to be no or minimal clinical outcome, it was found that the hemorrhagic complications were found to be alarming in these patients beyond 4.5 hours. So beyond 4.5 hours, it is a case-to-case decision based on the experience and the interaction with the patient's family, whether to proceed with thrombolysis or not. There is another trial which has been studied thereafter, which studied endovascular treatment alone. Why do thrombolysis if you know that there's a large vessel blocked and you know that thrombectomy is going to work? Why at all do thrombolysis? So this has been, in this trial, they have found that only mechanical thrombectomy without thrombolysis is non-inferior. So it is a non-inferiority trial, like we had the carotid stenting non-inferior to endarterectomy. Maybe in future, if you have a patient who is going to a hospital and there's a large vessel occlusion which is found, maybe the future would be to directly shift the patient to cath lab in a tertiary care center where all facilities are available if the timing is appropriate. So as we know, the heart and brain don't like delays, but how much delay is enough for the brain to tolerate or not tolerate is a question. So that is why pathways are being created. Pathways help us guide even a novel person or a patient who is new to kind of follow a protocol, or a person who is in the emergency to follow a protocol about how to go about and what are the timings to be followed. See, the ideal timing is within 60 minutes from the time of onset of, arrival of patient to the emergency. The workup, the clinical evaluation, the workup, and the thrombolysis have to be done. And because you have a time window of up to 6 hours doesn't mean that you can wait for the last minute for the patient to go to the cath lab. The idea is to push the patient after immediate thrombolysis as early as possible to the cath lab. Now, the clinical examination is a little bit cumbersome. If you see the criteria, most of them use the NIHS scale criteria. And if you look at the scale, it's so complicated. These scales are available in the ER, but if you have to do a rapid assessment, you see that it's practically a little bit challenging. So the simplest way is a patient who has got a gaze preference to one side, which indicates that the major vessel is blocked. Similarly, if a patient has got aphasia with weakness on one of the body, that also indicates that a major vessel is blocked. Similarly, if a patient is not able to hold the hand in the air for 10 seconds or leg in the air for 5 seconds, that means it is a major stroke. So these are simple thumb rules which can guide you whether a patient has got a major stroke or not. It's not necessarily in the tertiary care center. These simple tips are important in the peripheral centers where NIHS scales are very difficult to implement. So that is where the awareness is important about just 4 or 5 parameters clinically, what you can see and what next investigation to do to save the patient from undergoing a permanent brain damage. So this is important because we know that up to 4.5 hours, thrombolysis can be done. 6 hours used to be the cutoff for mechanical thrombectomy, but with the availability of the advanced imaging modalities like the perfusion imaging, the MRI and CT perfusion images, and the softwares which can deliver the report within 10 minutes without the need for a radiologist, that time window has been extended up to 24 hours. What if the patient is in a periphery center? If the peripheral center, if you identify a stroke, start the thrombolysis, which is called a drip, ship, and grip. So drip, the thrombolysis drip is started or a bolus is started in the periphery. The patient is being shifted to the nearest tertiary care center or a comprehensive stroke center. A pre-notification is very important in such patients because you can always keep the cath lab or ready or the staff ready, and then grip the clot is an effective strategy which is described for these interventions. So this is the final pathway. Less than 4.5 hours, CT or CT angiogram for the anterior circulation. For a posterior circulation, an MRI is a better option. Fulfills the criteria for thrombolysis. There are so many exclusion criteria. I'm sure the exclusion criteria will be similar for the heart as well. Go ahead with the thrombolysis. Again, tenecteplase versus arteplase, there is no difference. Many people are moving towards tenecteplase for the because of the effective thrombolysis, less complications, and less cost involved. If there is a large vessel occlusion involved, then endovascular therapy may be used as a bridging protocol. If the time window is between 4.5 to 24 hours, or if the onset of stroke is not known, for example, it's a wake-up stroke, then it is compulsory to do a particular imaging protocol to see the salvageable tissue, which is based on the CT perfusion or the MR perfusion. And you can either take the help of a radiologist or use the artificial intelligence software and then go ahead either with thrombolysis. Thrombolysis is of no role beyond 24 hours. So the only option available is endovascular therapy. More than 24 hours, usually the brain is infarcted in almost all cases. So it's only medical therapy or watch anti-edema measures and decompressive craniotomy were indicated. Very rarely, if the patient was lucky enough to have good collaterals, then you can assess the salvageable tissue or do an imaging to look for any stenosis which can precipitate another episode of stroke, and you can correct that. There are some special situations like stroke thrombolysis in the 3 to 4.5 hour window where the age is more than 80 years. Oral anticoagulants are being used. A patient has got a severe stroke or a combination of ischemic stroke and diabetes, which are controversial topics, so I will not be touching about it. Similarly, patients who are on anticoagulants, whether to reverse it before anticoagulation or not is a question before thrombolysis, but that's not a contraindication for endovascular therapy. Similarly, posterior circulation stroke is a totally different ballgame. The criteria are totally different. On a case-to-case basis, one needs to decide. Similarly, the endovascular therapy for medial vessel occlusions, I think next speaker will be talking about it. So to conclude, at the end of the, though it's sort of a busy slides and a lot of things, who is eligible for thrombectomy, the thrombolysis, any patient who has got a salvageable brain tissue, no hemorrhage on CT scan within the first 4.5 hours is eligible for thrombolysis. And thrombectomy patient up to 24 hours, depending on how much of tissue can be salvaged. Available techniques I have described. Success rate with thrombolysis alone is around 40%, whereas if you bridge it with mechanical thrombectomy, it can go up to 80%. And this has to be explained to the patient that success rate, I mean, is not just opening up the vessel, because recovery takes up to 90 days. So when we talk about success in stroke interventions, we talk about the 90-day period of either functional recovery at the end of 90 days. Thanks for the opportunity.
Thank you, Dr. Rajesh, for covering it up so well and making it simpler. And Suresh, you can start connecting the next laptop. I think so if anybody has any doubts or questions, you can feel free. How correct is the AI interpretation where how much brain can be saved? Now, suppose the radiologist senior is interpreting and you get a report on AI, though it is evolving, I think your impression I'm asking.
Yeah. So like I said, so AI depends on, like if you're doing a CT imaging, there are so many parameters, variable parameters, which can affect the outcomes, like the contrast dye, how much, at what speed it is pushed, and what frames it is being screened. And we have to do an early phase, arterial phase, early venous phase, and late venous phase. So all those parameters need to be standardized before actually transferring to the AI. Otherwise, it will interpret.
So once it is standardized, suppose a center like Apollo, you standardize everything and sending it AI. Now you feel AI can be reasonably okay, at least 90% okay, like compared to radiologist interpretation. No, we are learning. All of us are learning. You need not be very definite about your impression. I'm asking because you are more experienced.
I think the operator himself has to go and see the images again before jumping on to the conclusion. It's just that it'll give a clue whether he needs to come to the hospital and then. But it's always better to cross-verify before intervening based purely on the results of AI.
Somebody was asking dosage of tenecteplase.
0.25 milligram per kg body weight up to a maximum of 25. And it's given as a bolus.
Okay. Any other doubts? Antiplatelet therapy preceding, like our.
Yeah, we've after thrombolysis, if the patient has improved within the first 24 hours, we start with a single antiplatelet. The BP is high because blood pressure control is a very integral part of this therapy. The BP it has to be maintained around 180. 100.
So, like in acute MI primary, you don't give antiplatelets prior. Do you
no,
don't
not
give
prior. After the
so there are some differences between acute MI, primary PCI, and stroke therapy. That's why I specifically asked, because those are different. All of you should understand those. And then probably primary, how primary PCI was a decade back, and stroke interventions are gradually evolving like that. And now the youngsters, whoever is interested, it'll be good because a lot of requirement is there. Now, previously people used to criticize saying that whether you're allowed, somebody puts a case and all that questions used to come. Now ACC, AHA and European Society for both stroke interventions as well as acute ACC, AHA heart, our group accepted, because no proper trained interventional neurointerventionists. All the cardiologists, if you're interested, you are allowed according to law to perform these procedures. I just want understand youngsters to gain interest and take it up, because a lot of requirement is there in the society. So if compared to stroke, acute MIs, strokes are so common, but very few interventional neurology procedures. So patients come in anyway you're there in the hospital for primary PCI. So if you get trained there, that will also help for the patients. I keep telling that. But interpretation, if it's done properly with the help of a neurologist and radiologist together, if you work like a team, it will be very good, obviously. We are good at going there and taking the catheter there very early, but some sort of aneurysm, some sort of abnormal connections, which neurologists and neurosurgeons or radiologists will be able to interpret it better. Combinedly, we can always do a good job. Because sometimes radiologists or neurologists could take more time to reach there. But whereas we in interventional cardiology are comfortable taking the catheters there to carotid so easily, and that will save a lot of time and effort. That's why I feel in centers like Apollo, where combined team approach is possible, though patient can be admitted and a neurologist, there's no problem. But therapy should be offered on time. That's why what we've been struggling for. I think with this, we can have some more questions later after the talk, Rajesh. Thank you for sparing your time. He's a very active neurosurgeon also, okay? But he's also passionate about stroke interventions. We have another young dynamic colleague, Suresh, who is a trained interventional neuroradiologist in Apollo. And we requested him to cover and show some of the procedures where we found this therapy to be useful, and various thrombectomy type of catheters and other things where it is useful. He'll cover up this aspect because first speaker already told us about selection, and then lytic therapy. He will cover up the interventional aspects of the stroke. Over to you, Suresh.
You don't have a map. You have a map.
How many of you sitting here who have exposure to primary PCI? I think obviously you have because the fellows there. How many of centers have stroke intervention programs also? Can you raise your hands? 1, 2, 3. So a lot of work needs to be done. Huh? All of you go back to centers and encourage your neurology colleagues, radiologists to work on this. Actually, at least if you're not going to interventions, the lytic therapy can be immediately adopted, is it not? The patient coming on time is again very important. But if he comes on time, you save a lot of problems. Patients with hemiplegia are densely falling down. So pathetic story. I feel all of us should take initiative in this to save patients. Okay.
Coming up, okay. This was the marker, and this is for this one. Okay, I can do it from here. Okay, good afternoon, everyone. At the outset, I want to thank Srinivas Kumar sir for giving this opportunity. So it's more of a technical talk. Again, this not technical talk, and so I'll try to discuss few things about the hardware and how we go about and how the outcomes are, and few real life examples. And Dr. Rajesh, the previous speaker, nicely covered all the indications and case selection and few of the case examples also. There are some connection issues. No. Do that. It's not coming. No, can you give the other one? The video is pretty good. I think it is done. Where is it? This one. Okay. Okay. Keep it aside. That. Yeah. So all the strokes what we encounter at the ER in our hospital or in your setup, they are not all amenable for the stroke intervention. That's the first point we want to, we should know. If you do a scan, simple angiography, MR angio or CT angio, if the vessel occlusion is not visible, still stroke will be there. So that is called a small vessel stroke. So the other one is the second image on the right side. You can see that vessel occlusion is there on the right side, some asymmetry you can see. And sorry. So that is called as large vessel occlusion, wherein the vessel occlusion is there on the right side and infarct in the form of that white thing. So this is called as large vessel occlusion. And that's what, wherein the intervention role is there. So what is the incidence? This is 2 out of 10. If you get 10 stroke codes in your ER, you get probably 2 cases which are amenable for intervention. Rest of the 8 are not amenable for intervention. They're all small vessel occlusions. So, and visible occlusion, visible arterial occlusion won't be there. So the incidence is only 20%. So in these cases, we need to filter out which is suitable for the intervention, and we try to change the anatomy and clear up the vessel. So thrombolysis has average around 20 to 30% of recanalization, whereas intervention has got the recanalization rate of around 80 to 90%, the recanalization rate of 80 to 90%. So that is why, irrespective of the site of the occlusion, you got these results. So this is what I want to stress upon, that only large vessel occlusions are amenable for intervention. So what are the large vessels? Large vessels are the internal cerebral artery, that is, which is marked in the pink, you can see there. That is in the anticirculation, and this middle cerebral artery also up to M2. The reason is what are the devices we have got currently? They can go up to 2 mm vessel. So 2 mm vessels are up to this point, distally up to M2, we can call it as. Those vessels we can chase up to 2 mm vessels, the diameter wise. So we can do it in into anticirculation in the ICA. The left image you can see. So this is the internal carotid artery, middle cerebral artery, M1 and M2. And in the post circulation, we can go up to basal at top and probably into the proximal PCS. So these are the target sites that we can chase. And guidelines, Dr. Rajesh already described very nicely in the previous talk. So guidelines, what they say is basically the window period is up to 24 hours. So that is a concluding thing. And the patients who are having small infarcts or moderate infarcts, these are the S candidates, and this is a no candidate. If you have a large infarct, you don't take that patient. And if you have an IC occlusion, MC occlusion, basal artery occlusion, you can simply take that patient. And window period is up to 24 hours. The same criteria people are extending up to beyond 24 hours also, but we need to be careful because it's not in the guidelines currently. So few case examples. So the white one is the infarct, and you can see the corresponding arterial occlusion. Symmetry is not there, you can see that. So this is the middle cerebral artery. This was the before image and this is the after image. This is the device that we have placed. This is called as the Solumbra technique. And clinicals wise, the patient was a 26-year-old female, and she is in second trimester. And thrombolysis was not indicated because of the pregnancy. And patient came with right hemiplegia and aphasia. So you can see that patient is immediately lifting up her right hand and right leg and telling her name. And she was discharged on day 3. So any kind of recanalization, whether you see it in the heart or in the brain, once you recanalize the vessel properly with a viable tissue, with a penumbral tissue, salvageable tissue is there, you see this kind of outcomes. So similarly, one more case. This time it is in the right side. This is the before image and this after image. You can see this entire territory which is showing kind of paucity. Now it is opened up. So this is the device that is placed inside. This is the clot. The clots usually they are they vary between 1 centimeter to 3 centimeters in length. So again, this patient was having this on-table improvement. You can see that he came with left side hemiplegia and an examination. I think this issue with the video. So he's lifting up his left hand and left leg immediately after the procedure. So this you see this is on day 2. So how do we achieve this kind of outcomes? Not only technical, but the case selection, all those things will come into picture when the outcome comes into the matter. So the first device which came historically, which was invented or which was used to be for recanalization, was it used as an accidental or inadvertently it was used for the intervention. Basically, this is a kind of nitinol cut. It's a kind of a sheet of a nitinol cut mesh which was folded in like a tube. So this is called as solitary device, and you can see the clots on that. So it is actually used for the stent tested coiling. Accidentally, in one case, the coil purposes it was used for retrieving the foreign body. Similarly, it was used for the clot retrieval also in 2009. And then onwards, further improvements were done on that particular device called as stent retriever or solitary device. So how we do? So sorry, this is actually. So how we do? First of all, we cross the clot with the microcatheter, and then whatever the stent I told, it is basically microcatheter deployable stent. So then we deploy the microcatheter, and after that we deploy the stent retriever. The stent retriever, once it is there, we keep it for some inhaling time, maybe 5 to 10 minutes. Ideally is 5 minutes. And after that, along with the clot and the stent retriever, both of them are pulled out. So stent retriever is a kind of stent with a attached wire to it. It can't be detached. Even if too much of force also, usually it is not detached. So very accidentally, if you reuse it for maybe many times, probably it may detach, but usually it won't detach from its parent stent strut. Some of the stent struts are made up of single wire along with the struts also. So in those cases, it is unusual to get detached. And after that, then you pull back and remove the entire clot structure. So to get the clot out. So this is the mechanism. So how to access the clot? The clot access is composed of triaxial system. So because whatever the target sites are very distal and tortuous in nature, we use kind of triaxial system which composed of a long sheath, an intermediate catheter, and a microcatheter. So these 3 systems are available. The outer sheaths are kind of 8 French guidings, or 6 French long sheaths. The inner one are 6 French guiding catheters, which can go up to middle cerebral artery. They are so malleable and can go up to middle cerebral artery. The innermost one is a microcatheter through which a stent retriever is deployed. So these are the specifications of the intermediate catheter, the green one. And coming to stent retriever, different designs are available. Out of which the left one, which is a parametric device, which kind of a folded sheet of the mesh with a radial force within it. So solitary is the one. So all these the third generation, the stent retriever is more of a kind of segmental type to get the clot properly as compared to the second generation ones. So what we are getting in the form of the solitaire as well as the Trevor retriever, these are second generation devices. So these are the specifications. They all come in the range of 4 to 6 mm. There are some baby stent retrievers also available, which are in the sizes of 2 to 3 mm. And these are the microcatheters. They're all 0.1 diameter, and the length up to 160 centimeters in diameter. So these are on fluoroscopy, it looks like this. So this is the stent retriever in the brain, in the middle cerebral artery in the right side. This is in the AP projection, this is the lateral projection. So this is a kind of third gen, the further modifiers of solitary device. You can see that this radiopaque markers, which are kind of impregnated within the body of the solitaire also. You can see up to here. So you see that whether it is properly deployed, it is properly expanded or not, you will come to know with the help of this particular the radiopaque markers. And what you are seeing as a tube here with a radio opaque ring kind of thing, this is the intermediate catheter. The size, the outer diameter is around 6 French, and we use basically both of them together, which is called as Solumbra technique. The technique requirements and all I'll let you know in the later slides. So this is a case example. It looks as if the MCA is patent here, entire MCA, but it is not. The inferior division is missing. So this entire area is missing here. Paucity is there, as you can see here. So this particular branch, which is supposed to be here, it is not seen. So this was crossed. You can see the meg cutter. And once you cross, we'll take a distal injection to see whether we are in the proper vessel or not, which is in the target vessel. So the same way in the lateral injection, you can see this is the entire paucity of the cortical vessels. So this particular vessel was crossed, and we did a meg cutter injection. So you can see the AP and lateral positions of the corresponding crossing and taking of the injections. After that, then we start deploying the stent retriever. You can see that the constrained stent retriever in the meg cutter. So while deploying, you should know where we want to deploy it. Probably site of the clot. So in this case, the site of the clot was here. So I would deploy the stent retriever probably 1/3 distally and 1/3 across the clot and 1/3 proximally. So that is what the plan was. So you can see that how it's getting deployed. So this is self-expandable stent retriever, and the meg cutter was deployed, and the got kind of withdrawn, and it's kind of getting expanded across the clot. And in the lateral image also, you can see that. So the distal target position, I don't want that distally. So I kind of pulled it out and try to expand it and deploy it across the clot. So once it is across it, then you can engage the intermediate catheter also into the mouth of the clot. So this is about deployment. And after that, you can see the recanalization after the pulling back of the entire system, retrieval of the entire system. You can see that this opening up of a new vessel, which is corresponding to a big territory, and it's on the left side. Patient came with complete hemiplegia and improved in 2 days' time. So a young guy in his late 30s. And this is the corresponding image of the same patient. You can see that open vessel. This entire territory is now open, which is showing paucity here. And another case, you can see that this is a basilar occlusion. So how a stent retriever is deployed, you can see that here is the probable clot, and it is the clot extent is from here to here, but the stent retriever we deployed quite significantly distally, so that the capturing extent of the clot will be significantly better as compared to just deploying it across the clot. So you can see after the deployment and after the retrieval, you can see the opening up of this particular basilar segment with some amount of atherosclerosis, intrinsic or atherosclerosis present. So these are the different territories and different sizing of the stent retrievers. So you need to use a proper size stent retriever. Otherwise, if you oversize it, it may share the vessel. If you undersize it, it may not capture the clot. So this is very important according to the size where you are chasing. Some patient may have a bigger vessel. Probably we need to adapt accordingly. Where the clot is there, the clot you'll come to know on the imaging. Accordingly, you can plan the intervention. So for a ICA terminus, which is a bigger vessel around 4.5 mm, so we used a 640 stent retriever. As you can see, this is the stent retriever. This is before and this is after. You can see the site of occlusion is completely opacified here, recanalized here. Whereas, sorry. So this is very distal location. You can see it's in the antecerebral artery. So there, the vessels are smaller in caliber. You can see it's around 1.5 mm. So we use a stent retriever. This is stent retriever mesh kind of thing. We used a diameter of 3 with a length of 32 mm. So we need to size it according to the vessel, target vessel. So how to get the best outcomes? Best outcomes is basically 50-50%, 50 clinical criteria. If you properly seeing the imaging, properly evaluating all the clinical factors, that gives that is very important. Proper case selection. Apart from that, technically, you need to have 3 things in consideration. First is that you need to open the vessel in its entirety, more than 50%, or you can say 100%. If you go open, the clinical outcome is going to be good. The second thing is you have to open the vessel at the first go. It is not a rule, but if you get it in the first go, the outcome is going to be better. Because the more the number of passes you are going and chasing, the time is going to elapse more. That's the first reason. Second thing, the number of passes you are taking, the clot is going to change the morphology, and the chance of getting it retrieved in the second or third passes will become more and more lesser. And the third thing is faster. If you get a first pass recanalization, obviously it is a faster recanalization. So always aim for the first pass recanalization and achieve at least 2C recanalization or TK3 recanalization. Means more than 50% of the territory you have to recanalize. So what are the techniques? Apart from the stent retriever technique, we have got the aspiration thrombectomy or a combined thrombectomy, called as the stent retriever or the solitaire plus penumbra, called as Solumbra technique. Why it is important? Some clots are very much amenable for retrieval from the stent retriever, like soft clots, longer clots, whereas very fibrin-rich clots are very resistant to stent retriever. So these are very good for the aspiration thrombectomy. So if you combine both of them instead of using singly, solely, so definitely you'll get a better outcome. So these are the factors, physical factors of the clots and their interaction with the stent retriever or the aspiration catheter. So few of the clot characteristics are in favor of the stent retriever, few of the clot characteristics are in the favor of the aspiration catheter. So it's better we use combinedly. So this is called as Solumbra technique or SAVE or BADAS. So many names are given. Where in the mouth of the clot, the aspiration catheter is present and the stent retriever is simultaneously deployed in a sequential fashion. So then you retrieve this assembly of stent retriever as well as aspiration or the intermediate catheter in toto after some invaling time. So this is called as Solumbra technique. So you can see that this is the Solumbra, this is the intermediate catheter in the fluoroscopy and this the stent retriever. You can see the before and after. So the why we are using combination of devices to get the first pass effect and to get the best outcome. So that this aspiration catheter also will be helpful to avoid any distal embolization of fragments of clots while you are pulling it out. So we want to get the best outcome at the first go. So then we will get the best clinical outcomes also. So another case, so you can see a level of occlusion. You can see the stent retriever and the aspiration catheter. The aspiration catheter sitting into the mouth of the clot, and you will get this kind of technical outcomes. Case examples again, posterior circulation strokes known to be very having the worst outcomes. Already brainstem significantly involved. You can see the before and after images. And at the time of presentation, he was intubated. The GCS was 5, and this is after 2 months. He was weaned off and did tracheostomy, and after tracheostomy, you can see that he is walking. Still some spasticity is there, but he is able to do his activities currently. Another case, complete right ICA occlusion, but cross flow is there. ICA is missing, but he was having recurrent TIA. We recanalized without any distal emboli. So here the problem is, while we are venturing into recanalization, you should not cause any distal embolization, pushing of the clot into the normal circulation distally. So you have to be very careful with your technique. And these are the clots that are taken out and use the patient. And this is a post-CABG patient. So ours is a very high volume cardiac center. So this is done recently last month. So post-CABG on day 2, we can see that the patient had dense hemiplegia and immediately called, and we did the CT perfusion. And you can see the complete revascularization, and this is on day 2. Patient was walking. Another case at 4.5 hours, you can see the on-table improvement, left MC occlusion, elderly lady. You can see that the vessel is completely recanalized after the thrombectomy. So this is my experience around 340 cases, which were analyzed 2 months back, out of which the window period was this I want to stress upon is that most of the patients which come to us are more than 6 hours window period. They are not up to less than 6 hours. Only 1/4 I can say they come in the less than 6 hours window period. Most of them are more than 6 hours. They come from periphery, and even if they come also, the decision taking time will be there, because of which the onset to puncture time will be more than 6 hours in most of the cases. But the outcomes are comparable. Outcomes are not lesser in patients who are more than 6 hours. So it is not the time window, but it is the tissue window that is more important. So if you are selecting the same set of patients with the same core of infarct, in whether you're taking less than 6 hours or more than 6 hours, the outcomes at the end of 3 months, although the patients who are coming at the less than 6 hours, the recovery will be faster, but the patients who are, if you are taking comparably same infarct core, the outcomes are comparable in the range of around 70%. So, but this is not as rosy as we had discussed. There are some practical issues and complications we should know of. Difficult target access will be there. Sometimes you may end up doing incomplete recolonization. And if you've done a very good technical angiographic outcome, but it may be futile if you are choosing a wrong patient. This is called as futile recolonization. And in India, in our setup, it's still awareness and acceptance an issue. Affordability is the most significant issue. Complication we should know of while retrieving the clot, the stent fever, it may cause subarachnoid hemorrhage, can be benign most of the times. If this perforation kind of thing is there, it may be sometimes may require decompression and it may affect the overall clinical outcome. And embolization distal territory, which is the most feared complication while venturing thrombectomy, and dissection of the access vessel, vasospasm, and intracerebral hemorrhage due to perforation of the vessel. So these are all the complications. And to conclude that, we should understand that recolonization rate is up to 90-95% is now described, but it won't transfer into clinical outcomes. Maybe a 20% difference will be there if you are selecting properly those patients. So 90% good outcome, good technical outcome, maybe transfer to 70% clinical outcome. And first pass effect up to 50% of cases is possible now. The better the first pass effect we get, the chance of clinical outcome will be better if you are choosing a correct patient. And once we are doing venturing into it, so we should know about the device compatibility. What is the kind of physics of the clot, whether it's fibrin rich or red, thrombin rich, by seeing the image and vascular anatomy and decision making and planning, all of them will come into picture. So technical outcome wise, you should always try to achieve 2C by 3 recolonization and faster and first pass effect for best outcome, best clinical outcomes. Clinical outcomes are the ones which we actually aim for rather than angiographic outcomes. So if you want to get it, probably you need to get these recolonization parameters. Thank you.
Thank you, Suresh, for covering it up well, and congratulations for good work which you're doing. You should be source of inspiration to a lot of youngsters here. And one thing, many of the times when you take up the procedure, one thing which you made it different was if a patient has a large stroke, like large MI, you're doing primary PCI, there's more benefit for us. But you mentioned that if the patient has a large stroke, it doesn't benefit. Huh?
That if you're doing less than 4 hours, probably some benefit may be there. And some benefit, I have a series of data of large cohorts, around 45 patients. In that, 30 patients improved at the end of three months. So sorry, 30% of patients means 12 patients only. So the problem is in India, if you say that out of 10 patients, 3 will improve, rest of the 7 will be bedbound. So most of them won't accept it as a procedure. So that is the
If they come very early also, they won't improve.
Sorry, sir?
If they come very early, within 1 hour also, they won't improve.
Most of the times, a large course, they won't improve.
Anyway, thank you. I think all of you should take more interest and there's more need requirement. Nowadays, people are smart enough to decide the process of earnings and things like that also. Those people will be rewarded much more than cardiologists also. That also keep in mind. So not only for that, but there is requirement, clinical necessity for patients. I think, thank you, Suresh. And any questions if you want to ask anything? Or else we'll go to another interesting newer intervention. Not relatively new, I would say. Post-COVID, we are seeing a lot of patients of pulmonary thromboembolism, which has actually become very common. Like it's almost every week we see 1-2 major pulmonary thromboembolism cases which going into hypotension, things like that.
Thank you.
So maybe COVID and other things contributed. So I think we thought requested Dr. Varsha was interested in this aspect of the PERT protocols and pulmonary thromboembolism. You will also encounter. Many of the times it will missed as ACS and ECG, some shows non-specific changes. I requested him to cover some of those things and I will enlighten you how we are dealing with this pulmonary thromboembolism patients, new PERT protocols. I think we are running short of time. I think we can limit to 15 minutes. In the end, as I am supposed to adjust anyway, I will promise you that I'll finish in my talk in 1-2 minutes just to give some stimulation about RDN. I think over to you, Varsha.
Yeah, good afternoon, everyone. I think at the outset, must thank Dr. Srinivas Kumar to actually create such a platform and have so much enthusiastic crowd available on a Sunday afternoon. listening to this. So I think I totally understand that I am standing between most of you and lunch, so I don't want to kind of waste time on a lot of theory, and let's try to discuss more practical aspects. So I think pulmonary embolism, as we all know, it's got a very high mortality, almost 20% mortality in 90 days, which is significantly higher than a run-of-the-mill STEMI. And there are various complications like bleeding from thrombolytics or anticoagulation at the outset. There is a high chance of recurrence, and CTPH, chronic thromboembolic pH, it's seen in almost 10 to 15% in a lot of registries. And of course, it entails a lot of psychosocial, psychological complications as well. And the bottom line is the functional limitation of almost 50% at the end of 1 year, which is actually pretty bad compared to a standard STEMI as well. So I'll kind of quickly run through this, basically a broad way. It's a little crowded slide, essentially trying to show how to screen for pulmonary embolism. Essentially, there are two very well-established Geneva and Wells criteria, which can be easily employed in the emergency to see if the patient has high risk or high likelihood of pulmonary embolism. And this is a slide. Once the pulmonary embolism is diagnosed, you kind of stratify them into a high risk, intermediate risk, and a low risk pulmonary embolism, based on which the treatment strategy and the decision to admit or not admit depends. So in brief, essentially a patient who's got shock, RV dysfunction, or hemodynamic instability in short, they form the high risk pulmonary straight off pulmonary embolisms, which warrant an immediate reperfusion therapy. And the patients who have low risk, essentially whose there is no RV dysfunction, troponins are normal, BNP are normal, they are the ones who fall under the low risk features, in whom you can kind of make a decision to basically discharge from the ER and just go ahead with an outpatient based anticoagulation. So essentially, what is the real world problem? What exactly happens to patients who come with pulmonary embolism? So acute PE is diagnosed most often the ER or in the ICUs, where less likely in the ward. So depending on the primary physician, the cardiologist may get involved. Sometimes the pulmonary medicine doctors are called because patient predominantly has sudden onset dyspnea. Critical care gets involved, or the general physician. And most of the time, independently, a treatment plan is made, whether to be conservative or whether to do some catheter-guided intervention. And in the end, the cardiologists get called again when the catheter-based intervention plan is made. So in the whole process, there's a lot of time that is lost. So the only way to kind of cut short this time is to have a team-based approach, wherein we have a pulmonary embolism response team with so many people involved. And then essentially you realize that different departments have different experience or exposure to pulmonary embolism. Like a patient, like a general physicians may not be seeing pulmonary embolism as often as the pulmonologist or the cardiologist see. And obviously the comfort with thrombolysis depends from physician to physician. We as cardiologists end up seeing a lot of patients with STEMI, manage them and given thrombolytics without a lot of fear and hesitation. But the same comfort may not be present with a critical care physician who see a lot of bleeding complications with even anticoagulation. And I think another important aspect is the awareness of catheter-guided options like mechanical thrombectomy or a catheter-guided thrombolysis. The lot of physicians don't seem to be aware of it. And most important of all is probably the sinking patient who needs an immediate bailout. Often there is a lot of time lost in a decision making, which needs to be cut short. So to streamline the management delays, basically the emerging concept is to actually form a PERT team, which includes doctors who kind of involved with the management of PE, starting from cardiology, hematology. Even a radiologist is actually available as a part of PERT team to give an immediate and prompt response, which kind of helps in disposing a treatment plan as soon as possible. So this is just a graphic to explain that patients seem to be hemodynamically stable for a significant amount of time, despite the presence of RV dysfunction. So even in the setting of RV dysfunction, you may feel the hemodynamics are stable, but they go to this point of no return where once the shock sets in, the mortality exponentially rises. So it's very important to actually catch this substrate of patients who do have significant RV dysfunction but are hemodynamically stable at present. Those are the guys who benefit most with intervening for pulmonary embolism. So this is just another interesting slide. Not only the patient outcome improves as the PERT protocol is implemented in a hospital, the Radiology reports also get significantly better. So if you can see the blue bar protocol and the red post, you can see even the radiologist's awareness of what the clinician finds important, like the ratio of RV versus LV, significantly improves because the radiologist also gets aware of what the clinical criteria are for our intervention and our management strategy. So most importantly, the length of stay reduces significantly, which obviously brings down the cost. And this is one of the recent meta-analysis, which kind of shows the survival of PERT patients significantly improves despite the severity of in terms of PACE score being the same. And what is interesting is this slide wherein the readmission is significantly better even among patients who were treated in a hospital without the PERT protocol because of the general improvement in the awareness. Again, yeah, this is just a meta-analysis which kind of shows an improved trend in the mortality and significantly lesser length of hospital stay and more use of advanced therapy in terms of mechanical thrombectomy or catheter-guided lysis. So I think I'll just go through a few case examples to kind of describe what we are doing. So this is a 75-year-old lady who had a recent total hip replacement. She was admitted exactly 10 days later with a syncope to the ER, at which time the blood pressure was 80/60. She was tachycardic and the saturation was only 88. So clinically, she had a very high PACE score of 220. It was a submassive pulmonary embolism. There is a high bleeding risk in view of recent surgery. In fact, this is one of the cases which prompted us to form the PERT team and implement it in our hospital. So this patient was seen by the orthopedic surgeon, was called for a cardiology consult. The on-call cardiologist just said cleared for wrote the order of thrombolysis if cleared by orthopedic surgeon. And the orthopedic surgeon said thrombolysis if cleared by cardiologist. So there was a kind of tug of war in the emergency and finally nothing got done. It was the next day when the matters got escalated and then things were kind of discussed in a multidisciplinary way. And we felt that the patient would possibly benefit from a catheter-guided lysis where you can kind of reduce the dose of thrombolytic therapy and watch for complication, at which time you can immediately stop the treatment. So this is the CT of the patient where you can see a significantly dilated right ventricle compared to the left. In fact, the RV by LV ratio was almost 1.2. And there is a saddle embolus in the main pulmonary artery, which is extending to the right and the left side, including to the lower branches. So this is the echo, forgive me for the bad, poor image quality. You can see a significantly dilated right ventricle compared to the left. I got a better picture of a McConnell sign in the coming up case examples. And you can also see the D-shaped septum. And there is an RV dysfunction in the form of a TAPC of 1.4 and a RV TDI of only 9.7. And this is the initial pulmonary angiogram with a 6F pigtail in the main pulmonary artery. You can see a significantly reduced vascular markings in the right mid and lower zone and the left lower zone. And there is some filling defect noted in the proximal right pulmonary artery. This patient received a 5 mg bolus tenecteplase followed by a 1 mg per hour infusion for 18 hours. There was a significant clinical improvement. So you can see the one on the left is the echo prior to lysis and the one on the right is the echo within 24 hours. There is this remarkable reduction in the size of the right ventricle with very visible improved functioning of the right ventricle. And this is the TAPC, which was 1.4 to begin with, had come to 1.7 and RV TDI of 9.7, which improved to 13.7. All this within a span of 24 hours, mind you. And the mean PA pressure had reduced from 29 to 12 in the cath. So this is another case of a 28-year-old gentleman who had absolutely no risk factors, came with 2-day history of dyspnea. He had mild hypotension, BP was in the range of 90/60 and was tachycardic at presentation, saturation was 90%. This was the CT at CT pulmonary angiogram, which showed a significantly dilated right atrium and right ventricle. And there is a thrombus mainly involving the left pulmonary artery, left main pulmonary artery. And the distal right pulmonary artery and the right lower lobe arteries were also significantly occluded with the thrombus. And this is a very classical McConnell sign where you could see a free wall hypokinesia with preserved apical contraction and massively dilated right ventricle and right atrium, and possible thrombus in the pulmonary artery, and the plaques view showing significantly dilated right atrium and a very classical D-shaped septum compressed by the dilated right ventricle. TAPSE was 1.4 to begin with, and his TR gradient was around 50. So this guy fell into a high-risk PACE. Anything more than 110 is considered high. PACE score was 132 with significant RV dysfunction. His troponin was also mildly elevated. But then he had no contraindication for thrombolysis, so we went ahead and gave him a full dose of IV tenecteplase. And within 24 hours, there's a significant clinical improvement. He was off inotropes and oxygen, and he was discharged on oral apixaban. We did not do a repeat angiogram. So as you can see, I have actually kept the annotations on this slide to just demonstrate. So this was done at around 3 a.m., which shows almost like a McConnell sign. And this was done exactly 20 hours later after thrombolysis. So within 24 hours, there was a significant reduction in the size of the right ventricle and improvement in the function of the right ventricle. So forgive me, the scales are different, but essentially the TR max of 50 had come down to 33 at the end of lysis. And you can see TR is also minimal, and the RV TDA had improved to 15.8. And this patient was essentially discharged in 3 days out of ICU within 24 hours. And this is, I think, a pretty much a challenging case. A 64-year-old lady who was recently diagnosed with CA cervix. She was on chemo and radiation. Last chemo was received 7 days prior to presentation. She had loose stools for 4 days, following by sudden onset dyspnea and chest discomfort for 1 day. At the time of presentation, her troponin was 2,300, D-dimer was 8,500, BP was 80/50, pulse rate of 144, and most worrying factor was it was immediately post-chemo, the platelet counts were only 39,000. So here we have a lady with the echo showing RV dysfunction and a high PACE score, who is a definite candidate for immediate reperfusion therapy. At the same time, she has contraindication for even use of heparin. So literally our hands are tied. So this was because she was sick and sinking, we had to take a decision. So we took her for an invasive mechanical thrombectomy. So this is a selective pulmonary angiogram on the right and the left side. As you can see, a clear filling defect in the right main pulmonary artery and paucity of vaporization in the upper and mid zone vessels. And there is also a filling defect in the right left pulmonary artery. So in fact, we had to kind of improvise and use over-the-shelf items too, because the Penumbra was going through a change in the distributorship in Hyderabad, and catheters was just not available. So we actually just took a regular long sheath and used a end-hole catheter, multi-purpose in JR, and we connected it to the Penumbra system and completed the mechanical thrombectomy in this patient. So how is Penumbra different from just a regular syringe aspirate? So this graphic clearly demonstrates that when you actually aspirate using a syringe, the vacuum falls within the first 15 to 20 seconds. It almost becomes zero. But Penumbra kind of gives you that sustained negative pressure, which helps in aspirating the thrombus more efficiently. So subsequent care, this patient was off inotropes and CPAP in the next 48 hours. She had stable renal parameters. We actually started transfusing platelets to maintain it above 50,000 to enable giving a heparin to her. She had wide fluctuations of APTT with unfractionated heparin, so we kept her on enoxaparin. And we did not consider catheter-guided lysis because the platelets were under 1 lakh, and that's a contraindication. So actual plan was if the patient's platelet dropped further and we are unable to give enoxaparin, we'd probably just place a retrievable IVC filter and discharge. But thankfully, in few days, the platelets improved and we could actually discharge her on anticoagulation. So in conclusion, I think these three cases kind of demonstrate the various varied presentation and therapeutic options in patients with pulmonary embolism, and rapid reperfusion is essentially indicated whenever patient has cardiogenic shock or RV dysfunction on echo or on biomarkers. Team-based approach any given day gives a faster and a uniform decision making, and catheter-guided interventions when needed in the form of mechanical thrombectomy or CDT. Yeah, I think this is very important. I found it very interesting, especially in treating PEs when decisions are probably more important than incisions. So I'll be happy to collaborate or help if somebody is willing to set up a PERT team at their respective places. Thank you.
Congratulations, Varsha, for establishing a PERT team protocol and probably helping patients in this post-COVID times where we are finding this more common. I think even if in your center don't have this penumbra and all the stuff, human body is very great. Even if you can suck a little thrombus out, even if you give 10-20% perfusion, still patients improve. Gradually, they'll improve further. But in the acute stage, there are instances where we are doing CPRs, massage, took the patients to cath lab. put a routine guide catheters into PAs and sucked thrombus, then instances where patients improved. Especially these young patients, they have a lot of reserve. So even if little is given, they will improve. But if you have all those stuff which he mentioned, penumbra and other things, you can continue to use it. But even not the best also, patients improve with little of the thrombectomy things which we do. I think if you have any other doubts on this, it is okay. Otherwise, other chronic thing which is developing for youngsters, I want to stimulate you. The other thing is another newer intervention which is coming up, apart from the acute interventions of thrombectomy alone, is when the patient goes into a phase of chronic thromboembolic PAH. Previously, only surgery was option. Many surgeons are worried to suck the thrombus because itself is a high-risk procedure, high mortality. Not many centers do it. So there's another new modality of therapy coming up which is actually balloon pulmonary artery dilatations. Distending, you take, there's different protocols designed. It's available in net also. If you want help, that also can be done, where you take pictures of pulmonary arteries and image the vessels, how the diffusely narrowed they are, and start dilating. The serial protocols are described. So that's where also chronic thrombosis, this is acute what you mentioned, chronic therapy also is coming up in the form of balloon pulmonary artery dilatations with appropriate size balloons with the stepped protocols. That is some of the youngsters who are also working with your pulmonology colleagues. There's another area of interest which is coming up. We had one, we collaborated with one center in US, one of our Indian colleague is interested. That's how we are trying to develop that protocol too. I think with this, I thank Varsha. If there's no questions to him, I'll just briefly cover up for 2 minutes on this renal denervation talk.
CTPA is freely available. It is the major diagnostic modality of choice. In the first 1 or 2 cases, I thought you based your decision entirely on the echo features. It should ideally be a CTPA.
CT was done in both the cases.
Both the cases.
In fact, the first case had a saddle embolus with a dilated RA and RV, and so was the case in the second case as well. So the diagnostic modality will definitely remain CT pulmonary angiogram. I don't think we'll take a decision to intervene or even thrombolize purely based on a echo alone in a patient who's hemodynamically stable and who's fit for transfer. So.
And it's very easy to make out for youngsters. The CT is filled with thrombus as shown. I think all of us, not only radiologists, even we can make it out easily. You become comfortable with those interpretations. One thing in the end, I wanted to stimulate all of you. I had a prepared talk, but there's no great thing in it. So what we were thinking, renal denervation was a failure before because it was always tested before as an alternative to medical therapy. That neither in angioplasty nor in any therapy, drugs cannot be replaced. If you try any modality as a replacement for drug therapy, it will fail. That was happening before for renal denervation therapy. Now it is modified and coming as a third pillar of therapy for hypertension. That is, first is non-pharmacological therapy like diet and salt restriction, things like that, which exercise, all that. Second is pharmacological therapy. We have effective drugs. And third pillar of hypertension is renal denervation therapy. Renal denervation therapy, interventional cardiology fellows or cardiology fellows, all of you know how to do a renal angiogram, no big deal in it. Once you do renal angiogram, previously the method of renal denervation, what we were doing was targeting only on the proximal renal arteries. Now the change is, it is thought to be distal renal arteries have more of innervations. So now this spiral catheter, which is available now for anybody, patients to be done procedures. Some centers are recognized. Fortunately, we are also recognized for it. That catheter can go deep inside. It goes on the regular 014 wire. It's very easy to do it. One thing I can tell you is safety is established and doing it is also not very challenging, but provided you need to get the patient and the right patient, it has to be done. Again, a team approach involving probably clinical cardiologist, interventional cardiologist, nephrology colleague goes a long way, and the hospitals also should support this therapy. But it is available and it can be used. Coming to the indications, which patient needs to be done, then previously it was targeted for totally very high risk patients that again could fail. So here, if you're targeting patients who already have 200 by 120 pressure in spite of 5 drug usage, You can work to some extent to decrease the pressure. Don't promise patients that it will totally make the blood pressures normal. But even if it's 10-20% decrease in systolic pressures, you know that it major declines in strokes, heart failures happen with each reduction of pressure. That's how I think as an alternative, it will help in all patients. It is being planned even for patients on CRF. Very minimal contrast usage is required. So that also can be done for CKD patients, definitely. But some patients young patients who don't want to take drugs, this is a therapy where drug non-compliant patient is also suited. If doesn't want to take drugs, he want to try with this, there's nothing wrong. Some of the insurances are also covering, provided the patient understands, and we can do the therapy safely. So as the difference between before to now, the renal denervation is there is slight change in the way we do the therapy. And the second thing is the indications are changed, and it is now being used as an alternative, one of the pillars for hypertension, not to replace drugs. So these are the things I wanted to mention. I think youngsters, few of you who are interested for this therapy can adopt into it and develop protocols in your hospitals too. I think because we're running slightly behind, all of you need to have lunch also. With these words, I'll close here. And unless anybody wants to say anything in the end, the concluding remarks or something like from some of you want to say any questions, thoughts before we close? I think I thank all of you, because nowadays doing program, the most challenging and most important thing is you're having a good audience. I think we should congratulate Lupin for getting 150 plus doctors, and I appreciate all of you sitting till very late also. Around 2 o'clock it is now, you are able to, that gives enthusiasm for us to conduct such programs. And we thank all of you and Lupin for making this possible. And there are some felicitations and some conclusion remarks from Lupin, which will follow. Over to you. Thank you.
Thank you so much, sir. So I would now request Dr. Sandeep Bansal, sir, to please come on stage, and Mr. Sandeep Sharma from Lupin. Please give a loud round of applause. Next, I would request Dr. Rajesh Reddy to please come on stage. Mr. Krishna will felicitate him. So I would request Mr. Krishna to please stay. Next, I would invite Dr. Suresh. Okay. So Dr. Varsha, if you can.